Day one, we heard how obesity is a psychological disease, how obesity is also a neurologic disease. We also heard how obesity is also a endocrine problem, and everything put together, all these problems are into the framework of PNI. And yesterday we had a discussion on how neurology, how brain is a very important organ in obesity. And when we are talking about brain, not only the neurology, but also the mind aspect of the brain deals a lot with obesity. And when I'm treating obesity, I need to see the mind, the brain, the neurological circuits, and the framework as such in terms of managing the obesity. We heard a lot about gut yesterday, the importance of gut microbiome, how to tackle the gut. Then in the evening, we had a good culinary session where we were taught about good recipes which are easy to make and which are still healthy, very less time consuming, followed by a nutrition workshop. The nutrition workshop gave us an idea and insight into how a meal planning should be done. What is the concept of right eating? What is the concept of GLP diet? What is the concept of inflammatory diet? So all these parameters put together, it was a good learning for past 2 days. Now to today and tomorrow, I promise you that we will have still more new things coming up. And today we will be mainly talking about the endocrine aspect and the core clinical aspects of obesity management. So today for the first talk, we have Dr. Anish Bahel. So Dr. Anish is a consultant endocrinologist at Apollo Sugar and BGS Hospital, Mysore. He runs his own wellness super specialty center, and he specializes in type 1 diabetes and autoimmune diseases of the thyroid. So he will be talking to us on how you clinically assess a patient with obesity and how do you look into in terms of obesity management. So when we are talking about a patient who comes to our clinics for obesity, hardly people come to obesity treatment as such, but they come through some or the other problem. They may come from gynecologists, they may come from, say, thyroid specialists, they may come from gyms, they may come from nutritionists, they may come from different medical problems like osteoarthritis or obstructive sleep apnea. And putting all the problems together, patient may land up to your clinic. And how do you really assess this patient? How do you get him to speak on obesity? That is what we'll hear Dr. Anish speaking on. So over to you, Dr. Anish, for the talk.
So this particular program, right from inception, it's been a great journey. I would say a lot of learning points for all of us. So I'm going to talk about clinical assessment of obesity, a case-based approach. Now, before I talk about how do we assess these patients clinically, this is one important aspect which I want to stress here. All these years, we have been looking at obesity as a standalone risk factor which contributes to cardiovascular disease, hypertension, dyslipidemia. It's only over the last maybe 1.5 years, 1.5 decades that obesity has been recognized as an independent chronic disease, just like diabetes, hypertension, dyslipidemia. And in fact, this is a very nice definition which is given by American Association of Clinical Endocrinologists called ABCD. So what they've said is that obesity is a adiposity-based chronic disease. So essentially, if you look at the definition of obesity at this point of time, this is what has been given by a lot of different organizations, but essentially all of them are on the same line, that it's a disease which is chronic, relapsing, progressive, which is characterized by excess adiposity, which in turn leads on to impaired health. So when we look at a patient with obesity, the two things that we need to do is, one, put a label of obesity on his prescription. That's very important. Most of it write diabetes, hypertension, dyslipidemia, IHD, hypothyroidism, bronchial asthma, and things like that. But none of us will make an attempt to write obesity there. So I think that's the first thing you should write, because then we understand, and the patient also understands that he has obesity as a disorder. And we need to address obesity the same way that we address diabetes or hypertension. Many times, we don't even look at patients' weight and talk about it to the patient. The patient comes to us with, say, diabetes or hypertension or some other problem, and he has obesity. We don't even make a attempt to talk to him about that. That's something which probably we need to change. And once we change it, we can make that difference, because the patient will start understanding that this is something which also needs to be addressed. Just to give you a statistics how big a problem it is, this is from the ICMR INDAP study. You can see here that uh, if you're looking at generalized obesity, 20 almost 30%, central adiposity 40%. This is what we are concerned about, right? Because it's the visceral adiposity which is responsible for all the metabolic complications that we are talking about. And if you look at the state-wise difference, you can see here Puducherry has the highest prevalence of about 53% generalized obesity, 61% abdominal obesity. Jharkhand is at the other end of the spectrum, little less. And this is something which we already know. If you look at the patients with the highest quintile as far as the wealth is concerned, so people who are affluent, and you compare them with people at the other end of the spectrum, the risk of obesity is almost 8 times more. So that's something again which needs to be considered. This is the most important slide. I think at the end of the day, if we can remember some of these figures, it will definitely help us. The reason it's important is because these are the cutoffs for various parameters from an Indian perspective. The most important thing would be that the cutoff for BMI is much lower in Indians. You can see here that anything less than 23 is taken as normal, between 23 and 25 is considered as overweight, and more than 25 is obesity. And then you grade it. More than 24 to 30 is grade 1, 30 to 35 is grade 2, and 35 and above is grade 3. Now, these thresholds are much lower compared to the WHO recommendation, because Indians, for the same amount of BMI, have a greater degree of adiposity. And that's the reason why the cutoffs need to be little lower in Indian patients. Now, when we talk about assessment of obesity, we generally, I would say that very, very few of us who probably even make an attempt to see a patient's height, weight, and calculate a BMI. That would be the first step. But now we are moving to a scenario wherein we are talking about using other anthropometric measures also. So the most important thing would be measurement of waist circumference, which is something which is easily doable. We can also use waist hip ratio, but waist circumference is more acceptable to a lot of doctors. It has more better correlation, and from a patient's perspective also, it is much easier to do. The cutoffs for Indian men would be 90, women would be about 80 centimeters. And this is another thing which is becoming very popular, waist to height ratio. So you look at the waist of the patient, waist circumference, and divide it by height. It should be less than 0.5. If it's more than 0.5, there is increased association with hypertension and other cardiovascular morbidity and mortality. Body fat is again something which is becoming popular, basically because of late there has been a greater usage of things like DEXA scan to look at distribution of adiposity, greater usage of bioimpedance to look at different kinds of distribution of fat. And that's the reason why we should also know this particular parameter. If overall fat is more than 25% in men and 30% in women, that's definitely significant. So these are some figures. If you can remember this, I think that'd be really good. The next thing is that when we look at a patient with BMI, we are not just looking at, we have to uh, grade that patient or stage that patient. Now there are a lot of staging of which are available. This is one which is most acceptable by almost various organizations, the Edmonton obesity staging system. So you start with the stage 0 where the patient has obesity but no apparent obesity related risk factors. Stage 1 would be somebody who probably has some subclinical risk factors, mild impairments. For example, let's say that the patient has pre-diabetes or pre-hypertension with obesity. Now at these two stages, the reason why you need to stage a patient is because it will help you to decide how aggressive you need to be managing these patients, what kind of intervention you need to have. Because when you talk about obesity management, we have 5 pillars of obesity management, right? The dietary intervention, exercise, pharmacotherapy, behavior therapy, and bariatric surgery. So we have to be very clear where to intervene with what kind of intervention. So if somebody is in stage 0 or stage 1, all we probably need is a lifestyle modification, talking about the eating pattern, the physical activity. We move to stage 2 where patient starts developing some obesity related complications, could be diabetes, hypertension. At this point of time, there is a role to intervene along with lifestyle with a pharmacotherapy and maybe a behavior therapy. Stage 3 and 4 is when the problems really become aggravated, and then you need to be more aggressive in managing these patients. Now, what would be surprising for most of you is that in India, about two-thirds of the patients are probably in stage 3 and stage 4, according to various studies. That means when you see a patient with obesity, the likelihood that he already has a complication and probably the complication has moved on to an advanced stage is pretty high. So, this is a slide which kind of gives you an overview of how obesity affects different organ systems. At this point of time, obesity has been linked with more than 200 disorders, and the association with these disorders is mild to um, significantly. There are certain disorders where the association is very, very significant. For example, diabetes, MSLD, these CVD. These are all conditions where the association between obesity and these conditions is very significant. And the other end of the spectrum, there would be somewhere that association is mild. But what we should understand is that almost every organ system of the body is affected by obesity, and that's the reason this is also important, because when you assess a patient, we need to at least look at some of these common derangements that can occur in patient with obesity, because that's a part of our clinical assessment. So if you have to start assessing a patient, you start with the basic things like a medical history, physical examination. These two are very important in obesity because the pattern of or the trajectory of weight gain would give us a fair good idea of what's happening in the background. Few things on the physical examination, labs. In this, when we are looking at the history, the finding, I mean, the clinical examination and the lab reports, we also need to look at various systems that are involved or that can get affected because of obesity, and we need to do targeted testing for the systems. I'll talk about that subsequently. And finally, the obesity graph. So when you talk about basic tests, the minimum basic test that would be do for patients would be lipids, sugar test, could be fasting, postprandial HbA1c, looking at thyroid tests, LFTs, CBC, uric acid. Mainly we look at LFTs and CBC to look at the FIB4 score, to look at presence of MSLD, a very common occurrence in patients with obesity and very common in Indian patients. That's something which we have to start doing. So there are some of these calculators that one should be utilizing when you are seeing patients with obesity. So the most important thing when you see a patient with obesity is that you have to look at the trajectory of weight gain. How has the weight gain been? Whether it's been a gradual weight gain or it's been a sudden weight gain. Because when somebody puts on weight suddenly, you are more likely to have some background disorder which is responsible for weight gain. For example, situations like hypothyroidism or Cushing's are situations where you can have a very rapid weight gain. So that will help you to how aggressively to investigate those patients. Somebody has been putting on weight gradually over a period of time. You know that you're more likely seeing a patient with obesity, which is primary in nature, not secondary to any other disorders. And it's also very important to understand that whether the patient has made any attempt to lose weight in the past. For example, a lot of patients would give you a history that when they go on a lifestyle modification, there is weight loss, but when they stop it again, they go. So that will give you an idea, because it will help you decide that how what kind of interventions you need to take in that patients. Overview of eating pattern is very important. See, definitely a dietitian is going to go probably in depth into these particular aspects, but when you're seeing a patient, at least grossly you can ask the patient about the eating pattern and get an idea what it is, whether the patient is what kind of intake is there, whether the food is definitely one of the culprit there. And obviously physical activity also needs to be looked at it, because in Indian context, physical activity is something which is definitely on the lower side. Now, we know that now let's look at certain other aspects. Now, globally, about 5% of obesity may have an underlying genetic component. Likely, in countries like India and Southeast Asia, where consanguineous marriages are very common, probably these figures may be definitely a little higher. At this point of time, there are three genetic defects which are monogenic defects which have been associated with obesity more commonly: the leptin gene defect, leptin receptor defect, and MCR4 mutations. In fact, studies have shown that about 30% of children with obesity in in presence of consanguinity may have these monogenic disorders. So these are some of the conditions, wherein probably you have to consider a genetic testing. So as you said, if it starts very early, morbid obesity, history of consanguinity, there is a family history of young onset obesity, hyperphagia, developmental delay. So these are some situations wherein you will think of genetic. Otherwise, in general, we will not ask for any genetic testing when we look at a patient with obesity. Now, we as endocrinologists come across this situation very often. A patient comes to us thinking that there is a hormone cause for his weight gain. So we should be very clear that what are the hormones which can cause obesity as a part of that particular syndrome, and how common they are. Now, these are I'll just listed these things. Let me tell you that these things are not so common. The only thing which would be common would be hypothyroidism, and obviously we are going to do a TSH for most patients who come to us with obesity. As far as adrenal disorders are concerned, Cushing's disease or Cushing syndrome could be a cause for this thing, but you have a very specific clues in the history and examination which will tell you that there is something in the background and probably need to evaluate. So we do what's called overnight dexamethasone suppression. So I'm not going to go in detail over it. Just this is just for completion's sake. Drug-induced dysfunction, drug-induced adrenal dysfunction is more common. The abuse of steroids, especially in patients with rheumatological condition, COPDs, asthmas, skin condition, is very rampant, and you are more likely to come across an iatrogenic Cushing's than endogenous Cushing's. There probably, if you have the background history of ingestion of steroids, many times patient will not come to directly with history of steroids. It will be always something in form of a powder or some alternate medication. So you have to be little more suspicious in that. So we just start with a basal ATM cortisol to see if the endogenous HPA axis is suppressed, because that will give you a clue that yes, this patient has probably an exogenous steroid abuse. As far as gonads are concerned, yes, endogenous deficiency is common in patients who are obesity, and there is a bidirectional relationship. Patients who are obese may have hypogonadism, and obesity itself may predispose to hypogonadism. So bidirections. Female gonads, the most important thing would be presence of PCOS. We know that PCOS is a very common problem. So again, when you see a female patient with weight gain, it's very important to look at the menstrual history, that because that will give you a clue. So somebody who's come to you with gradual weight gain over a period of time, there is oligomenorrhea, there may be some features of hyperandrogenism. If those things are there, then probably you are looking at PCOS, and that needs to be worked up. So these are some of the tests which we do in these situations. These are tests. I would like to stress here that these tests are asked for only when you have clues from the examination and a history. Then only you look for it. Otherwise, you don't ask these tests in a routine workup of obesity. Pituitary, again, growth hormone deficiency is very common, but it's associated with obesity. Hypopit, again, growth hormone deficiency as a part of hypopit would be responsible for obesity. And then you have these acquired hypothalamic syndromes. There, the patient will have histories like severe hyperphagia and some other clues will be there. These are all rare things. Just for completion's sake, I'm just giving you an idea that what endocrine disorders can be associated with obesity. There's a condition called pseudo-hypoparathyroidism, which is a very classical, what is called AHO phenotype. And if you've seen one of these things, short stature, short fourth matter couples, then you will pick it up. Otherwise, again, in clinical practice, we don't look for all this. Hypothalamic obesity syndromes, these are very rare disorders, but that's something which has to be kept in the back. So essentially, the reason I listed those endocrine disorders just to give you an idea that all these disorders can be associated with obesity, but the chances of you picking it up in general clinical practice is very low. So you look for those things only when you have a clue in the history and examination. Otherwise, you don't look in that particular direction. Now, as far as the workup is concerned, I've told you the certain list of tests we do. Then you do specific tests to look at the associated complication. For example, metabolic complication, we are mainly concerned about diabetes, metabolic syndrome, NFLD, dyslipidemia. So as a part of that, we would be asking a patient for blood sugars, fasting, postprandials, HbA1c. We will ask for a lipid profile. We'll ask for LFTs. We'll ask for a CBC and look at the FIB4 score. So that's what would be a part to look at the associated metabolic complications. This should be done as a routine because the association of these conditions with obesity is very, very high. Cardiovascular complications, again, dyslipidemia, hypertension would be very common. And as a part of normal workup, when a patient comes to us, we would be asking, we would obviously look at anthropometry, we are going to look at height, weight, BMI, we are going to look at blood pressure. So that would be this thing. And cardiovascular disease, again, a lot of patients who are obese would have history of exertional dyspnea. Many times it may not point to an obvious IHD because a lot of these patients may also have obesity per se would reduce their exercise tolerance, and a lot of these patients will have a little difficulty on doing physical exertion. Then these are all organ specific things. As I said, you look for these, you will get a clue in the history itself, whether you're talking about PCOS, hypogonadism, OSA, asthma, osteoarthritis, incontinence, GERD. So all these things should be specifically asked for when you are asking a patient about history. Again, this is something which off late we have started paying more attention. All of us physicians probably, don't pay too much of attention to the psychological aspect of a disease process. We look at things from a very physical point of view, but obesity is one disorder which has lots of associated psychological issues, and probably that needs to be addressed, because all these depression, anxiety, binge eating, and all could be a problem in these patients. And if it's there, then we need to take a help of a psychiatric colleague or somebody who will help us with that particular patient. So these are some of the things that we look at from a patient's perspective. So I'll just show you 2-3 cases just to show you how the thought process works in these patients. Now we have a patient who's 43 years old, diabetic since 5 years. This patient has put on a lot of weight, about 6 to 7 kgs over the last 1 year. The sugars are fairly well controlled. Now the thing is that the patient is on 3 drugs: glimepiride, metformin, pioglitazone. Now when you see a patient like this, the first thing which comes to our mind is that yes, this patient has probably put on weight because of pioglitazone. So drug-induced obesity, especially in diabetes, is very common, because pioglitazone is a drug which the usage of that drug has come down compared to what it was, let's say, about 15-20 years back, but it's still there. As far as an anti-diabetic drug is concerned, pioglitazone is a wonderful drug because it gives you very good control of sugars. It has a very good long-term, stability as far as glycemic control is concerned. But it can cause weight gain, normally 1 to 2 kgs, 3 kgs. But there are some patients who can put on a lot of weight. So if that's a scenario, you have to think of knocking it off. So what's very important, the learning point in this case is that if you start a patient with pioglitazone, because a 43 years old male, pioglitazone is a good drug to start. If you start a patient on pioglitazone, you have to keep a very close watch on weight, and if the patient is putting on excessive weight, probably you have to stop it. So in a patient like this, the first thing would be to stop pioglitazone. And as an alternate, you can start a patient on a drug like dapagliflozin or empagliflozin. SGLT inhibitors are drugs which can cause weight loss. And in the present day scenario, we can also talk about a GLP-1 analogs, drugs which have, especially drugs like semaglutide, which have gone off patent, which are available at maybe a fraction of cost what they were available 1 year back. So that those are options which are there in a patient like this. So just a word about when we treat patients with diabetes and obesity. Now what we should understand is that there are 2 drugs which can cause weight loss: GLP-1 analog and SGLT inhibitors. Though bigonides, a lot of people say can cause weight loss, but I personally believe that I would put bigonides in this column where they are weight neutral, rather than, because they usually do not cause weight loss. Pramlintide is an amino analog which is not available in India, but that's again another drug that causes weight loss. So when you see an anti-diabetic prescription, there are only 2 drugs from Indian context which can cause weight loss. One is the SGLT inhibitors, the other one is GLP analogs. Drugs like gliptin, AGIs, I would put metformin in this category, also are kind of weight neutral. So you see a patient who's obese, when you use these kind of drugs, you are very sure that the patient is not going to put on weight. This is something which is, drugs like insulin, glitazones, and SUs are the drugs which cause weight gain, especially when you don't use them properly. Because one of the reasons, glitazones, obviously, as I said, weight gain is a part of the action of that particular drug. So if there's a lot of weight gain, you need to stop it. Insulin and sulfonylureas, probably you have to look at the background recurrent hypos, binge eating, defensive eating, defensive snacking, which can be responsible for weight gain. There are certain psychiatric drugs which are quite commonly used in practice. For example, amitriptyline is very commonly used for diabetic neuropathy, which is a very common accompaniment of diabetes that can cause weight gain. And certain other drugs used by psychiatrists can also lead to, for example, drugs like olanzapine and all can cause hyperglycemia as well as weight gain. So those are things which you should be aware of. Another case is a 45 years old lady who's coming in with weight gain, fatigue, puffiness of the face. So this is the lady, you can see here that she has puffiness of the face, periorbital. Now, other thing which clues that patient has a diffuse goiter. So when you see a patient like this, weight gain, puffiness of the face, fatigue, and you have a goiter, the first thing which comes to mind that you are probably dealing with hypothyroidism. That's what this patient had. Now, what we do is, obviously, we start the patient on thyroxine, and over a period of time, we titrate the dose based on TSH levels, symptomatology, and things like that. Now, what I would like to stress here is that we need to explain to the patient certain things very clearly when somebody comes to us with obesity and who's newly diagnosed with hypothyroidism. That the first thing is that symptomatically, now things like facial puffiness, fatigue, tiredness, body pains, all those would improve gradually once you start a patient on thyroxine and once the thyroid status becomes normal. But the weight gain aspect may not normalize. A lot of patients who come to us with newly diagnosed hypothyroidism and weight gain expect that whatever weight they have put on, they will lose that weight once we start them on thyroxine. That's probably not going to happen. That's something we have to tell the patients right at the beginning, that now in this particular patient case, the patient has put on about 7 kgs of weight. The chances are that the patient may lose 2 or 3 kgs or maybe 4 kgs, but they're not going to come back to baselines. That's something which you have to stress very, very clearly when you see patients with hypothyroidism. So I look at another case. This is a 38 years old female. She has 4 kids, two of them born, the LSCS. She's put on a lot of weight, but it's been a gradual weight gain over a period of about 5 years. Now, basically, again, this is a very common scenario which we see. The patient comes to us saying that I'm putting on a lot of weight. I want to rule out hypothyroidism, because the social media awareness about hypothyroidism and thyroid disorder is very high. So many times these patients would do a thyroid test and come to us with the report. The only thing is this patient is definitely on the obese side. BMI is 33. Otherwise, very unremarkable examination. The only other thing she has is some markers of insulin resistance. Now, this patient has an abnormal thyroid test where only isolated TSH is high. Now, the other thing which you have is presence of markers of insulin resistance like acanthosis nigricans, skin tags. So, this is something again which is very common when you see patients with obesity, especially in Indian context. Now, what if you look at the TFTs, the TSH is 6.3. Now, this patient would come to you. I'm sure you definitely would be seeing these kind of patients in your practice. This patient would come to you thinking that the TSH of 6.3 is responsible for that 15 kgs of weight gain in the last 5 years. They don't understand that that's just an incidental finding. So the point here, learning point here is that many patients who are obese may have elevation of TSH, which is not because of thyroid dysfunction, right? Here, basically, there would be alteration in the hypothalamo hypothalamo pituitary thyroid axis because of changes in outside the axis. So these patients who are obese may have increased leptin levels, which is correlated with the adiposity, and leptin tends to increase TRH, that is TSH receptor hormone, at the hypothalamic level, which in turn would increase TSH. So many times you will see patients who come to you with obesity with BMI of 35, 40, with a TSH of 6, 7, 8. Those patients probably don't have a thyroid dysfunction. Those patients most likely have obesity related elevation in TSH. And these are the patients where even if you put them on thyroxine, you are not going to get much benefit. So this patient probably does not need a thyroxine therapy. I would not start. What I would do in such a patient is maybe look for a presence of goiter, look for history of family history of thyroid disease, look for anti-thyroid antibodies. If any of these things are there, then maybe I can give a trial of thyroxine. But if none of these are there, probably I would explain to the patient that your TSH increase is more related to obesity rather than uh, increased TSH causing weight gain. This patient probably has obesity because of gradual weight gain over a period of, she has had multiple pregnancies. For a woman, pregnancy, postpartum period, and then perimenopausal period. These are 3 epochs in their life when the tendency to put on weight is very strong. So somebody who's had multiple pregnancies is going to put on weight after each pregnancy, which is never going to come back to baseline. And that's the reason after 2 or 3 pregnancies, they would have already gained 10 to 12 kgs from the baseline. And then probably most of them don't accept the fact that that is because of this reason, and they're looking at some secondary causes. Last case is a lady who, this is a classical case of Cushing's. This lady has come to us with a sudden weight gain. You can see the quantum of weight gain, 10 kgs in 4 to 5 months. So the patient is very clear that 4-5 months back the patient was so much, and suddenly the patient has put on weight. So this is definitely a clue that there is something else which is causing weight gain. And the other problem the patient comes to us with is that she has difficulty climbing the stairs. So this is the lady. On examination, she had facial plethora, hirsutism, she had proximal myopathy, which was clinically evident. There were stria. Now the stria which you see in Cushing's are usually wide, livid, and they're very. If you've seen 1 or 2 of those strias, you will not miss it again. You also see stria in obesity also, but they tend to be very narrow. They're not as livid as this. Most of them would be whitish. And this patient has also easy bruisability. Again, a clue that patient may have steroid excess. So this patient was worked up. So we do a series of tests. We start with what's called ODS cortisol, LDS cortisol. We look at ACTH levels, and depending on that, we have a protocol. This patient is diagnosed to have Cushing's disease. So essentially, Cushing's disease is there's a pituitary macroadenoma, most of the time microadenoma, which is producing excess ACTH, which in turn would increase the cortisol levels. So this patient underwent a transpenoidal surgery of the pituitary adenoma, and just see the remarkable change. So this is the patient at presentation. This is within days after surgery, and this is patient 3 months after. You can see the remarkable change in the facial features, right? So these are all rarities. These are not common things. I just wanted to show you that you think of these things only when you have a specific history which is there. So I just like to sum up by saying that when you see a patient with obesity, you start with basics, with history examination. That gives you fair amount of clue that whether you're dealing with any specific disease which is in causing weight gain, or you're dealing with idiopathic obesity. And then the next step would be to ask for certain basic tests and some directed tests based on the clinical profile of the patient. And then you start the process of treating this patient. So with that, I come to the end of my talk. Thanks a lot for patient hearing.
Thank you so much, sir, for your insightful presentation. And now I would like to invite Suhas Gopal Erande sir on stage. He is Dr. Suhas Gopal Erande is a diabetologist and internal medicines. Some of the services provided by the doctor are prevention, diagnosis, and managing various diabetes complications like cardiovascular disease, diabetic foot disease, retinopathy, eye damage, neuropathy, nerve damage, skin condition, adult diabetes, diabetes management, and insulins, etc. Suhas Erinde sir is MD Medicine University of Pune, Diploma in Diabetes Care University of Newcastle, Australia, practicing consultancy diabetologist since last 40 years in Pune, Akshay Hospital and Insulin Pump Center, Pune, IDMR Research Fellow in Diabetes, National Faculty API RSSDI CID, Jericon National Platform, written chapters and medical update API textbook last 6 years, 20 years international published reference and counting member, diabetes, what is that? Vitra Award for Social Work in Diabetes Awareness in Pune 2016.
Thank you, Dr. Vaishali, for the kind invitation here. I would be speaking about something which is unusual in the 2026 GLP era, but nonetheless, it is a established method of managing obesity. In some other areas like psychiatry and behavioral disorder, this is something which is an established treatment. But obesity, we are trying to actually find our feet. How do you really do neuromodulation? So the scenario has already been now made aware of by previous speaker, Dr. Ashish. We have a big problem of obesity in our country. And you can, if you really focus on what is the National Health and Family Survey, so practically a quarter of the women and maybe around same number of men, they are either overweight or obese in our country. So it's a major public health problem, and not only obesity, but the surrounding problems like the hypertension, ischemic heart failure, diabetes, muscle, all these associated problems, if not the higher risk of GI malignancies and psychological distress, all these can really be a big problem. So we have different authorities like maybe UNICEF, like the ICMR, like the central government of India, which I have just now shown, and then there are other agencies also which have looked at obesity. Importantly, obesity is not only an adult problem, but it's a problem in the children and adolescents as well. So the prevalence of obesity among the adult Indians, we certainly have a higher ranking in the global system. We rank third behind probably US and China. And in 2021 itself, 25.40 crores adults had general obesity and 35 odd crores were abdominal obesity. In fact, Dr. Ashish has paid attention adequately to the central obesity when he was teaching about the assessment of obesity in his presentation. And other important thing is the annual growth rates of overweight obesity in adults projected to be 4.1% by 2035. So it's a huge problem, and that's the reason why beyond the established lifestyle, diet, exercise, drugs, bariatric surgery, we need to really keep on trying to find out more and more, majority of the times that's lacking, but more and more newer methods. So this is from the United Kingdom government, a recent editorial. So they say that the UK government has recently announced 12 innovative pilot projects which are funded by the Obesity Pathway Innovation Program. And this is something which is trying to really look at various other methods, barring which I mentioned. That's something which is being looked at. So these are our own Press Bureau of Information figures. So driving the rise of obesity in India, various aspects. Certainly most of the experts here are aware of that. But point is, our changing lifestyle most of the times is the culprit, and not only the adults, but even the children and adolescents are getting more influenced by the changing world around them. So what's the relevance of neuromodulation? In fact, we had a brief talk with Dr. Vaishali that what is expected out of me. So the point here is why this is relevant in the GLP-1 era, because this is the era of drugs, and the drugs are very efficacious. So still, why are we discussing neuromodulation? So we need to pay attention to some of the important factors. For example, the nature of obesity itself, it's a multi-pronged disease. So it could be genetic. Dr. Ashish had shown some examples of the same, though they are rare. Then it could be hormonal, it could be environmental, it could be behavioral, and it could be certainly psychopathological. In fact, the authorities have added even the political as one of the causes of obesity. So that is something which we have to really appreciate. It's a lifelong and chronic recurring, the definition itself. So it's a lifelong rebound phenomenon. People take drugs, whatever drugs, may be efficacious or not, but they take drugs, they get fed up of those drugs, they stop it, and the weight again comes back. We know it very well. So these are the situations where the other ways of managing obesity are important. Then GLP-1, if we really talk about as the main drug to handle obesity in 2026, that is something which is ridden with lot of side effects. And we know that quite a few will not be able to tolerate the drug in the first place. Some will somehow continue, but down the line they will quit the drugs. That also is another established fact across the globe. So in these two situations, we are to again have something which is a different way of looking at obesity management. And then targeting specific biological subtypes. We know that roughly 25% of the individuals with obesity can be called as non-responders or maybe poor responders. This is ultimately biology. So the GLP responders may be, you can say, not 100%, but less because of the GLP-1 receptors, which are probably less in those. There could be some where the GIP receptors are good, so GLP-GIP combo can work. But there are some who don't respond to the dual analogs also. The triples and more are still, you can say, to be used by us. But well, yes, biology ultimately could prevail. So we have to have some other measures to handle obesity beyond the drug treatment. And the most important, the food noise and the cravings. Techniques like repetitive transcranial magnetic stimulation, RTMS, stimulate the executive function of the brain, which is probably something which controls the behavior, or the impulses will be inhibited in a technical word, and that is related to cell control. So GLP-1 can reduce appetite. Neuromodulation can directly alter the psychological drive to overeat by interrupting the addiction or reward pathways in the brain. So all these need to be considered when we are talking about neuromodulation. These are some interesting physiological or structural things. This is brain functional and structural MRI. These are the images. And technically, this is something which is a fairly crowded site. But the important point here is obesity has, you can say, multiple foci or multiple locations in the brain which could probably handle different aspect. Everything may not be a specific area. There could be intermingling of the controls and the areas. However, there is something which is the appetite. There is something which is impaired decision making about eating, impaired eating control, impulses, and poor inhibition is something which is again important. In fact, there are various observations where those who are normal eaters compared to those who are binge eaters, there are some areas of the prefrontal cortex, especially the crura and the amygdala. That is something which is less developed in people who have habit of binge eating. That takes us to maybe bringing up the next generation. So there are quite a few countries where up to a certain age of the child, maybe around 6 years or so, the child is not supposed to be given any kind of added sugar as a diet or maybe added salt as a diet. That's probably to develop these areas in a more robust way so that the inhibitory control is better. So these actually slides shows us various areas of the brain which are concerned with motivation, homeostasis, the reward which the person gets out of eating a particular foodstuff, so to say, and then maybe the self-control, the processing of the decisions, etc., etc. And then the phenomena like higher food craving, delayed satiety, etc., etc. So these are very, you can say, these are the different kinds of magnetic resonance imaging which are done, and these may be, you can say, called as task MRIs and resting state MRIs, so on and so forth. And you can see the anatomical locations, like for example, the frontal cortex, the mesolimbic regions, the subcortical regions, hypothalamus, the precuneus or the somatosensory pathways. And the variables which are looked at are the food cues or the taste or the olfactory sensations, cognition, so on and so forth. So these are very, very relevant, and they have been studied in obese people especially, to give us a better understanding to develop drugs which could probably handle the specific pathways or the specific loci in the brain which can probably handle the eating patterns better. So the clinical problem is fairly clear. We have a huge problem of obesity in our country and across the globe, and obesity needs new therapeutic tools every other, you can say, era, because 40% of bariatric surgery patients regain significant weight. The Swedish obesity study of the mid-90s, now it completed 3 decades. And we know now that for some time, bariatric surgery certainly gives a robust weight loss, maybe up to 30% or more. And comorbids like maybe hypertension, diabetes especially, patient may not need any kind of pharmacotherapy for the same. But as time passes, all these comorbidities, they come back. So that is something, and weight also can come back. Psychiatric issues are not to be really mentioned. Swedish obesity study, quite a few have committed suicides. That's also a published kind of thing. 3 times the rise of global obesity since 1975, you can add maybe 4 also there. And the FDA's first approved vagus nerve stimulation, one of the modalities of neuromodulation, it was used for epilepsy to start with. But now, since 2015, obesity also is one indication where vagus nerve stimulation has been FDA approved. So behavioral and pharmacological treatments are often insufficient for severe obesity. Surgery, while effective, is invasive. Everybody may not really accept it. Everybody may not be really fit enough to undergo a full-fledged bariatric surgery. Surgery is something which is mostly it is irreversible and not suitable or acceptable for quite a few. So this gap has driven an interest in the different way of thinking. So it's neuromodulation, which is reversible, which is not invasive, it is adjustable, and maybe for some patients, it can certainly handle the hunger, satiety, and the reward mechanism more efficiently than any kind of other modality. So what's neuromodulation? In obesity, neuromodulation targets the circuits which regulate energy balance, the hypothalamus, homeostatic hunger, satiety signals chiefly, the mesolimbic reward pathways, the hedonic eating, and the vagus nerve, which is the gut-brain signaling of fullness. All these can be certainly looked at. The prefrontal cortex, which is the executive part of the eating or the restraint, that is something also which can be considered under neuromodulation. So neuromodulation modalities could be either invasive, which is surgically implanted devices delivering direct, continuous or closed loop stimuli that is DBS, that is deep brain stimulation, vagal nerve stimulation also in an invasive way, gastric electric stimulation, etc. Then there are some non-invasive modalities like, for example, external stimulation through the scalp or the skin. There is no surgery involved. So this is magnetic stimulation, then direct cutaneous stimulation, transcutaneous vagal nerve stimulation, etc. And then there are some more like targeted circuits for hypothalamic satiety centers, reward or craving pathways, and vagal gut-brain afferents. We will see briefly what is done. This is like, you can say, I am discussing something which is a appendectomy operation in a classroom, not in an operation theater. So VNS or vagal nerve stimulation, main gut to brain cable, so to say, cervical VNS, which is implantable pulse generator on the chest and leads on the vagus in the neck. This is research as such. Then vagal block, abdominal vagal nerve stimulation, which is a laparoscopic. The leads on the vagal trunks are placed at the esophageal gastric junction. Intermittent blockade at around 8, and you can expect around 8 to 10% of weight loss also. These are the vagal nerve stimulation mechanisms are FDA approved from 2015. And the TAVNS, which is you can say something which is on the clip, on the, so to say, mastoid. And this is the ear clips which stimulate the auricular branch of the vagus. And these are undergoing phase 2 and phase 3 trials. This is an at-home. So the patient himself is going to operate that, non-invasive. Generally, the machine is kept on around 10 minutes prior to the meal. So like a maybe pre-meal bolus insulin, so to say. Then the gastric esophageal stimulation implants or electrodes are directly put in the stomach wall to slow the gastric emptying and send early satiety signals. So the intention is same, but the ways with which that is done could be either non-invasive or invasive. Then the other mechanisms, like for example, endoscopic neuromodulation, endoscopic placement of the device, which is essentially a battery-free neuromodulator mini implant in the stomach wall, submucosal region, and targets the vagal afferents. Duodenal mucosal resurfacing, which is an established endobarrier method, and that can be combined with this particular mechanism of neurostimulation, and the combination is right now in early research. This is lesser invasive than the vagal block completely. Deep brain stimulation, like deep brain or hypothalamic stimulation electrodes, this is a neurosurgical domain. It is experimental and used very rarely in all those genetic obesity people which Dr. Ashish had mentioned in his talk. So these, you can say, are the broad descriptions of the neuromodulation. Coming back to what we are more familiar with because of the GLP days, these are the various regions of the brain, like for example, the hypothalamus, the arcuate nucleus, the first order neurons, and the peptides acting on that, and then the various hormones which have actually been, now everybody can rattle that with, you can say, easy memory, the NPY, the AGRP, POMC and CRT, etc. The MC34R, about the mutation of which can give rise to genetic obesity, again was also mentioned by Dr. Ashish. The point which we can certainly focus on is the last one. These are the vagal afferents. The vagal afferents reach the nucleus tractus solitarius, and then the feeding, gastric emptying, metabolic rates are something which can be influenced by the vagal afferents. And that is the one area which is out of the cranium, easier for the non-invasive as well as invasive approaches to really attack. Again, an invasive diagram from the textbook of endocrinology, Williams. Again, I will take your attention not only to the various obesity drugs like the GLP, GIPs, or maybe the naltrexone, bupropion, topiramate, so on and so forth, acting at various centers in the brain. But look at that. These are the parasympathetic system and the sympathetic systems, which again are something which are out of the cranium, probably something where the invasive or the non-invasive approaches could be tried in various ways. So this is a more advanced kind of thing. This is yet an animal experimentation. So active devices and systems for closed loop neuromodulation, they could be either electronic, they could be thermal, they could be magnetic, mechanical, or maybe optic. So these are again something which is undergoing animal experimentation at this particular time. This is the latest technology exhibition which was held in Ireland, and this is the scientist who had actually exhibited his findings there. So this is a device which delivers a low-level electrical pulse behind the ear. As I told you, the auricular branch of the vagus. It was developed under the leadership of Dr. McEwan, who is depicted there, a 31-year-old neuroscientist who has a medical degree from the University of Belfast. There is a other way of looking at it. It is more invasive again, but in the animals. This is a device designed to stimulate the neural structure to increase weight loss in people with diabetes, with obesity. Researchers of Washington University are developing an endovascular stimulation device which can be implanted in an artery or vein to provide stimulation to the nearby neural structures to treat obesity. Despite significant advances, current weight loss solutions remain either intolerable, inaccessible, or ineffective in many patients. So, this device is implanted in the T6, thoracic 6 radicular artery, and stimulates the T6 spinal nerve, then works through a somatoautonomic reflex with the vagus nerve branches to the stomach to enhance the weight loss in people with obesity. In at least pig experiment, this has certainly succeeded in attaining more than 10% of weight loss as well. Mind you, these are not the naturally obese pigs, these are pigs who have been high fat diet kind of thing. So this is a diagrammatic representation of the same. Now, some trials or some maybe analysis. For example, the use of non-invasive brain stimulation techniques to reduce weight and food craving. These are classical human observations. This is Clinical Obesity 2023. And two variables are looked at. For example, on the left-hand side, you can see the effects on the appetite. On the right-hand side, you can see the effects on the weight. And mostly, you will see that the diamond actually shifts in favor of the neuromodulation. So the appetite is certainly controlled better and the weight loss also is better. It is not to the tune of the GLP-1 analogs, mind you, but maybe around 8 to 10% of weight loss in a best of scenario can certainly be expected with non-invasive vagal nerve stimulation. So the primary investigation in this particular observation did reveal a huge decrease of body weight and body mass. Results also showed a significant benefit of non-invasive brain stimulation on lowering the food cravings. And findings also expose that whereas only 20 minutes of the stimulation had a significant impact on cravings, both 20 and 30 minutes had an impact on the body weight also. So if the patient can tolerate, the stimulation can be done not for 10 minutes but for prolonged time, and you can expect a more aggressive weight loss. So the findings of this particular report potentially lend support to the growing evidence that non-invasive brain stimulation can certainly reduce food cravings, reduce the body weight as well, and most of the patients can tolerate this to a certain extent. Another experiment or another observation, American Journal of Clinical Nutrition. So neuromodulation directed at the prefrontal cortex, the executive eating, so to say, or the restraint, that's the part of the brain which executes that. And this is looking at the snack food intake and hunger, and this is a randomized controlled trial. The test done is snack food test, so SFTT, and intervention is the transcranial direct current stimulation, again non-invasive. So there are two, you can say, groups. One is the anodal transdermal cranial stimulation, and then it's only a sham group. And total energy intake, you can see on that side, there certainly is better. It has reduced in the anodal stimulated people compared to the sham stimulation, and the candies consumed, they are certainly lesser compared to the sham stimulus. So this is very interesting, but this is something which is practicable, and that's why actually I have tried to show it to the audience here. Again, the variables here, the person's craving has come down, and compared to the sham stimulus, the actual stimulus certainly reduces the craving, reduces the amount of calories which the person consumes, and certainly proves to be a good method of weight loss. All these may be non-invasive, but mind you, some patients will have some kind of problems. So there could be headaches, there could be neck pains, there could be scalp pains, scalp burning, and skin redness, sleepiness. So all these could probably be side effects of these non-invasive neuromodulatory method as well. So the vagus nerve stimulation is something which is more popular and maybe approved for a long period of time. So the fundamental mechanism is it stimulates the vagal afferents carrying the satiety and gastric distension signals from the gut to the brain. This is FDA approved, as I told you. The newer closed loop systems sense the gastric activity and stimulate in response, aiming for more physiological signaling. In fact, the latest one is a very small vibrating pill which the person consumes, and it stays in the stomach for maybe around 30 to 45 minutes, and it keeps on giving intermittent vibratory stimuli to the gastric mucosa, thereby stimulating the vagal afferents and giving a sense of fullness. The person has not eaten at all. So these methods are certainly coming up. Transcutaneous through the ear, as I have told you, or through the neck, that vagal nerve stimulation is under investigation as a non-invasive alternative, and also engages the cholinergic anti-inflammatory pathways of interest for obesity-related metabolic inflammation. So now they are trying to probably enter the featherweight, but try to box at the heavyweight also. An intelligent implantable modulator of vagus nerve function for treatment of obesity, that is something which is now in vogue, called as I2MOVE project. And again, this is something which is certainly leading one of the important interventions, and they are trying to do it at a mass level. That's why it is called as a I2MOVE project. Two fundamental things: whether that can be tolerated, and two, what is the efficacy as far as the weight loss across different shades of obesity in the population are concerned. So that's the something which is going on right now. Deep brain stimulation is something which is probably, as I told you, the neurosurgical area. So there is a direct modulation of hunger and reward circuitry. Either the lateral hypothalamus, core homeostatic hunger satiety regulator, classic deep brain stimulation target. Nucleus accumbens, the reward circuit hub, targeted to reduce hedonic and craving kind of overeating, and the ventral striatum involved in the food-related reward processing and compulsive eating behavior. So deep brain stimulation for obesity remains extremely investigational. Evidence draws on its established safety in movement disorders and psychiatric conditions, obsessive compulsive depression, or some refractory cases of depression, etc. But this is something which is a invasive methodology of neuromodulation. So non-invasive brain stimulation by transcranial magnetic stimulation, more popular. Transcranial direct current stimulation, again something which is popular. It can be used as an episode or spells, or it can be done repeatedly in a single sitting. This is fairly well tolerated. Gastric electrical stimulation. This is again something which is coming up quite popularly. Direct stimulation of the stomach wall. Endoscopic procedures, electrodes implanted on or in the gastric wall, deliver electrical impulses intended to alter the gastric motility, promote early satiety, and modulate the gut hormone signaling. So these are the methods which certainly are coming up. As I told you, along with the mucosal resurfacing, duodenal mucosal resurfacing, gastric electrical stimulation, a combination approach is certainly giving quite a good results, and few unpublished results are coming from our Indian colleagues as well. So if you really try to compare the approaches of different neuromodulation methodologies, so vagus nerve stimulation, deep brain stimulation, vagus nerve stimulation could be either invasive or transcutaneous. Vagal gut afferents are the target, and the evidence strength is moderate or strong in some cases. Some methodologies have been approved by US FDA 2015. Deep brain stimulation is certainly invasive. It's a surgical implant. I told you that it is a neurosurgical domain. It is investigational for obesity, established in some psychiatric indications. Gastric electrical stimulation is again invasive. Gastric motility and satiety is looked at. Large trial base is certainly there. Mixed results as yet. And the regulatory status that can differ by the device which is being used by that particular investigator. Then the stimulation or the direct stimulation they are again non-invasive. They look at the prefrontal cortex or the cortical excitability. The results again are modest, and they are right now investigational as far as approvals are concerned. So these are the overall challenges and open questions. We have to have robust trials. The effect size needs to be established, and established over a longer period of time. The devices, accesses, and the patient selection certainly has to be more categorical in all these patient groups. Before winding up, something which is going on maybe more non-invasively and maybe a different mechanical method. So this is clinical study of wearable low intensity pulse ultrasound treatment in improvement of executive function in the brain, also called as slight trial. So this is the protocol. Of course, this is a trial, so naturally there are some inclusion and exclusion criteria as well. Non-invasive neuromodulation techniques like transcranial direct current stimulation and transcranial magnetic stimulation have demonstrated fair potential in improving executive function and assisting weight reduction. Low intensity pulsed ultrasound or LIPUS represents an emerging neuromodulation technique distinguished by non-invasive application, superior spatial resolution, and facilitating targeted modulation of cortical activity and neuronal excitability with more precision. So these are the inclusion and exclusion criteria for most of the neuromodulations. Naturally, you need to rule out head trauma, epileptic disorders, presence or absence of other metallic implants, pacemakers, patients who has claustrophobia, and all these needs to be essentially ruled out, and then the patient can be taken for the intervention. Diagnosis of psychiatric disorders or current psychotropic medications also is certainly to be excluded, and abnormal MRI images, any structural brain problem, the patient will not be a good candidate for neuromodulation. So LIPUS is something which is emerging technology, and these are the different variables, so to say. The patient will be shown an image of a food and his desire to go for the food or no go for the food. That is something which is picked up by a gadget. And then there are some other variables which will be looked at. Even the EEG and the MRI, functional MRI, also will be looked at. Oh, this is a gadget which the LIPUS examiners use. And now certainly they have not only entered it as a featherweight, but now they have entered in heavyweight also. So neuromodulation, the future of diabetes treatment, this is again something which has been proclaimed by a group of investigators. Again, the vagus nerve is being looked at. So this is something which is the anterior trunk of the vagus that is supplying the hepatic branch, and the posterior which is supplying the pancreas. And they are trying to neuromodulate these two so that the diabetic metabolic problem can be looked at. So my friends, as I told you, this is something which is trying to talk about appendectomy in the classroom, not in the operation theater. But there are some good aspects here, future directions like closed loop systems, real-time sensing of gastric or metabolic signals to trigger stimulation only when needed, and improving the precision, improving the battery life. Combo therapies, which I have already told you, pairing neuromodulation with GLP-1 receptor agonists or behavioral programs to boost and sustain weight loss. Better patient stratification using neuromodulation and metabolic phenotyping to match patients to the technique most likely to help them. And even the anti-inflammatory pathways, which I briefly mentioned, the vagal nerve stimulation effect on systemic inflammation being explored for obesity-related liver and metabolic problems beyond the weight loss. So neuromodulation is not yet a first-line obesity treatment, very obviously, but vagal nerve stimulation's regulatory approval and growing mechanistic understanding position of the field as a promising reversible complement to the existing pharmacological and surgical interventions can certainly be a new era in looking at obesity. Till such time, the good old reduction of cooking oil, the dietary discipline, avoiding sugars, and maybe doing mass level exercises, that's something which will be the backbone of managing obesity. Thank you, my friends, for your kind attention. Thank you so much.
Thank you so much, sir, for your excellent talk. Now, I would like to invite Dr. Amit Natsankar, sir. So, Amit Natsankar, sir, has completed his qualification in MBBS in BJ Medical College, MD in General Medicines, and DNB in Endocrinology. He is having 15 years of experience as associate professor in medicines, 11 years experience as endocrinologist. 40 national and international publications, reviewer of various national and international medical and endocrinology journals, Dr. NB Endocrinology Guide and Examiner. Consulted endocrinologist in FD Hospital Guwahati, life member Endocrinology Society of India, editor Journal of Diabetes and Endocrinology Clinic. Now I would like to request to Come Dr. Amit Nachankar sir on stage.
First of all, I should thank Dr. Vaishali Madam for giving an opportunity to talk in this August forum. Secondly, I should also thank Dr. Anish sir for setting the background for this talk, because some of the aspects have been discussed by him. So my topic, body fat analysis. I shall be covering this under following headings. Obesity, as already discussed. Why body fat analysis? What are the methods? What is the interpretation? How the artificial intelligence is coming up in body fat analysis. So as earlier described, Endocrine Society has given guidance for BMI-based obesity classifications. However, we know classical example of YY paradox, that is Dr. Yudkin and Dr. Yagnik, who had same BMI. However, their body fat was different. So this is the background that there is fallacy for body mass index. What are the fallacies? Firstly, for given BMI, percentage of body fat may not be the same. It changes with sex, more in females, as you have heard, ethnicity, more in Indians as compared to Caucasians, and it varies with the age also. Elderly populations have extremes of age, it is less. So it is not a sensitive indicator of body fat and metabolic risk, especially in Indians, and it is responsible for the insulin resistance and metabolic diseases, ultimately leading to cardiovascular morbidity and mortality. Eventually, body fat analysis also helps in assessing the benefits of the intervention that we plan. The treatment modalities has been discussed so far. We see before treatment how much was body fat, after treatment how much is body fat, and that gives a clue. So what is body fat? We know body has got fat which is divided into various portions like subcutaneous, which may be superficial or deep subcutaneous adipose tissue, or it could be internal adipose tissue, which could be visceral or non-visceral. In visceral also we know intrathoracic, intra-abdominopelvic, then in intrathoracic it comes intrapericardial, extrapericardial. Similarly, intra-abdominopelvic it can be intraperitoneal and extraperitoneal. So there is various description. However, what we can assess in body fat mainly in visceral adipose tissue and subcutaneous adipose tissue. This is important thing in that what is our body compositions? We know body has got fat. Once we exclude fat, it is fat-free mass. So this fat-free mass has also composed of various components like proteins, carbohydrates, soft tissue, minerals, and comes fats. So there are different compartment models has been described in the body. If you see a single compartment, entire body, which can be examined by body weight alone. However, it does not give you how much is the body fat. If you divide it into fat mass and fat-free mass, most of the techniques helps in assessing fat-free mass. So you reduce total fat-free mass from the total body weight, we get the fat mass. And there is 3 compartment model mostly assessed by DEXA, in which we give further separate fat-free mass into bone mineral content. So it gives lean mass plus fat bone mineral content, which together gives as fat-free mass. And fat mass is, as I mentioned, composed of adipose tissue alone. There are certain complex models also, in which there is 4 compartment model where they further divide that fat-free mass into metabolic tissue or multi-compartment model. But however, since this is a mixed crowd, I'll go into more of the up to 3 component models. So these are simple formulas. Body fat is nothing but body weight minus fat-free mass. What is fat-free mass? It is nothing but lean mass plus bone mineral content. And what is body cell mass? Body cell mass is nothing but visceral protein plus intracellular water. So the extracellular water is excluded from cell because it is extracellular. And the formula for calculating body cell mass is nothing but we have to reduce extracellular water and bone mineral component from the fat-free mass. I hope I'm following. If you can see, this is slightly easier interpretation. So fat-free mass and this is fat mass, entire body. Total body water of which intracellular becomes the part of body cell mass. Extracellular and bone mineral does not form. So lean mass will be from visceral protein, intracellular water and extracellular water. So based on this staging, we know the being a body-mind body composition. So we know body is made of atoms. They in turn form molecules like proteins, lipids, and eventually they form part of cells. So in the cell there is extracellular solids or fluids and cell mass. And these cells form tissues and eventually forms the entire body. So based on this, there are various techniques that have come into picture, which part to be assessed. Since today's topic is body fat analysis, I'll particularly focus on this fat mass or the adipose tissue. If you see, the fat mass is assessed by various methods like air displacement plethysmography, bioelectrical impedance analysis, DEXA scan, 3D optical scans. Similarly, adipose tissue can be assessed at the level of tissue organ based on imaging modalities. Whole body weight is not a significant indicator because, as we mentioned, the body mass index may be variable. As earlier described by Dr. Anis, weight, BMI, waist circumference, they are important. However, they do not fully give idea about entire body fat. Waist circumference gives idea about visceral adipose tissue. Skin fold thickness gives indication about what is the subcutaneous fat content. Especially in children, it may be fallacious, and it is calculated at the level of triceps skin fold thickness or subscapular skin fold thickness. In triceps, they are taking normal value as 12 to 15 millimeters in adults, and at subscapular thickness, they take value of around 18 to 20 millimeters. Then comes body bioelectric impedance. This is a two component. Here we calculate fat, body water, and measure fat-free mass. They reduce from total body weight. Whereas there are certain research-based methods like isotope dilution techniques for body water that can also be used, but mainly in the research setting. Bioimpedance assay is the one commonly used in most of the centers, even in many of the gyms, wellness centers, and it is non-invasive and no radiation required. DEXA scan, which I shall be discussing in detail in further, which gives assessment of regional body fat. What is the composition in the trunk, what is the arms, legs, etc. CT scan, because of the radiation hazard, though precise, not commonly used. So is the case of MRI. Coming to bioelectrical impedance analysis. Here we use electrical conductive properties of the body for various water, electrolytes, fat, and they measure the impedance or interference that occur at various currents. It could be various frequencies, different types are there. However, there can be error because if the limb length is different, nutritional extremes of obesity and cachexia, it may not be correct. Hydration, if somebody goes drinking a lot of water immediately goes for testing of bioimpedance analysis, it may be lean mass may be exhibited higher. Also, there are variations with ovulation, incorrect placement of electrodes. So in such cases, these errors can be mitigated by use of bioimpedance spectroscopy or using of multi-frequency BIA. So various types are there. single frequency to multi-frequency spectroscopy. Single frequency are cheaper. As the frequency increases, cost increases. Electrodes, whether they are tetrafluoro or octafluoro, they are different. Different type of electrodes, they are adhesive or contact. These are technical terms which I am discussing in minor details, especially for those who are planning to install these equipments in their clinics. So they should know what is necessary, what all equipments are required. Higher ends are required mainly for research purposes. Then the position of the body can be standing, supine, or seated. You can do whole body analysis of fat, or you can do segmental analysis only for waist or only for foot to foot. The devices are variable. They can be portable, home scale, bathroom type, or they could be consumer accessible or stationary. And they are using either free based equations, predictable, or proprietary empirical equations. If you see commonly used in body analysis, this first one is 120, which is cheaper, around up to 2 lakhs. This is 260 in body, which comes up to 5 lakhs. These are enough for basically clinic based only for body fat composition analysis. Everybody can install it. It is easily printable. Papers comes, a report comes. This is in body 770. It comes around 18 lakhs, and it is more of the research grade. It is multi-frequency. It gives variable analysis of variable fats. So this is standing posture in which routinely body composition analysis is done with the electrodes held in hand, and there is foot position. Important thing is preparation. Anybody can go and do not get the test done. Better to not consume food for 8 hours. So fasting is preferred. Do not drink any water 2 hours prior to testing. Do not exercise 24 hours because the water content of the body changes. No alcohol for 48 hours. And you have to empty bladder and intestine at least 30 minutes prior to that, so that you can get accurate readings. So this is typical in body composition analysis for 120 or 260 S. Sorry for the image quality. Here you can see the percentage body fat. It gives total body fat here in kilograms, and percentage it is showing 31.8%. And it also gives segmental analysis of the body fat. This is in body 770S, which has given additional data also. Here if you see, the body fat percentage is 35. And it gives total volume. It has another 5-6 pages which I am not demonstrating now. So as I mentioned, that was entire body fat. But there are certain machines which are dual, which can detect not only whole body, but for particular segments. Like say this part of this machine called as dual BA, which can assess only visceral fat of the abdomen only. So here they basically place 2 electrical parts on to measure inner abdominal and abdominal surface impedance. And it is classical precision based method that visceral fat assessment is done. Apart from that, there are portable abdominal BI analysis for visceral fat estimation called as Y-scope, which if you see here, it comes like in this format, Y-scope. You have to apply on the particular segment of the body, and it gives interface charging and it gives exact assessment. Coming to DEXA. DEXA is considered as gold standard. BIA, that is body impedance analysis, gives slightly 4% less amount of fat as compared to DEXA, though it is 96% value of the DEXA. But DEXA is considered as gold standard because it uses X-rays, though the quantity of X-ray that is exposed patient is less than the daily exposure of background radiation. So you don't need to worry about the radiation hazard that comes with CT scans. And it gives error of only 1.6 kilogram with respect to higher 4 component body composition models. Only drawback is it assumes fat amount over bone similar to bone free tissue. and we cannot use it in children less than 2 years. So this is typical hologic DEXA machine, mainly used for bone mineral density assessment, but it can also be used for body composition analysis. The position is important. Position should be, patient should lie flat on the table. There should not be any pillow. Then upper lungs, that is, they should lie along the body, either side. Legs should be slightly internally rotated. And there should not be overlap of any of the body parts. The chin is slightly extended. And there are certain regional technical lines that DEXA technicians should be aware of how to do body composition analysis. Like if you see, here there is one line that is below jaw lines. It is important. It should be marked. Then there is waist line, which is above the iliac crest. Then there are two perpendicular lines which separate the trunk from the limbs. And there is one groin line which should cross across the neck of femur on either side. And there is one line which separates trunk from the limb. It is across the glenohumeral joint coming down straight. So the importance is that this pelvis line helps in assessment of the separation between the android part of the body from gynoid part, and which is important, which I'll come to next part. There are certain errors technician might make which you should see before interpretation of the results. Like there should not be any overlap of hand with any body parts, like you can see here. The line should be properly marked. If you see, this waistline is slightly lower than the actual waistline, which should have been here. So these are technical things which should be aware before you interpret, otherwise the results may be fallacious. So what is the typical DEXA report looks like? If you see, here you get body composition results, exact amount of fat, lean mass which is present in the body. And here you get the adiposity indices. So what are these adiposity indices? What is percentage body fat, which already has described in the first lecture, what should be normal. Then other than that, what is fat mass index? So if you see in this patient, the body percentage fat is 56.6%. As I mentioned, as has been mentioned earlier, normal in men is less than 25%, in females less than 30%. So it is obviously high. This is another example. If you see, the body mass index of this patient is around 24. However, total body fat is 40%. So this is called as normal weight obesity. Though BMI is normal, the fat mass is high. So it is important that you should know this concept of normal weight obesity, and that has been explored in great detail in this body fat analysis report. Then there was one Kerala diabetes prevention program which had shown that almost 37% of individuals have got normal weight obesity. And they have also cardiovascular outcomes, morbidity similar to that seen in higher BMI, even though their BMI is normal. This is another example. If you see, obviously BMI is 30, total body fat is 52.7%, and here there is concept called as fat mass divided by height square. Here it is coming 63.3. So this is concept analogous to body mass index. And there are certain fat mass index has been given for Caucasian population, Indian Asian populations, and it correlates with the body mass index. So total for males it is considered normal is 3 to 6. And if you see in previous slide, it is 16.3. So this is obviously obesity. Then there is concept of appendicular lean height, appendicular lean mass divided by height square. This is 5.3. That is lean mass. It should be higher. In males, it should be more than 7 kilogram per meter square, and females it should be more than 6 kilogram per meter square. So these are the concepts. When you analyze the report, you should see into these details. As analogous to body mass index, fat mass index is important, and we should always go for fat mass index because it gives correlations with worsening of cardiovascular and metabolic outcomes. So these are the enhanced data for various FMIs compared to the BMI for the population as well as the male or female as well as the cutoffs. So what we are taking is below 6 for males, 3 to 6 and 5 to 9 for females. Sorry, 3 to 6 for males and 5 to 9 for females in non-Caucasians. Next, coming to the another adiposity index is android to gynoid fat mass ratio. It is DEXA analog of West-Hip ratio that we calculate. West-Hip ratio, as earlier mentioned, less than 0.8 for females, less than 0.9 for males. So similarly, the ratio between android region, between which is calculated as last thoracic rib, as I mentioned in earlier slide, and the upper part of iliac wings, to that gynoid region, which is gluteofemoral region with upper horizontal line below the pelvis line that I have mentioned earlier, up to the lower horizontal line by measuring the twice the height of android region. If I can, okay, in next slide I might show you. So here is AG ratio. If you can see AG ratio, it should be less than 1. If it is more than 1, it suggests there is android type of obesity. Visceral fat mass is higher. So this is another parameter that we should be aware of, because it is the visceral fat that is responsible for most of the cardiovascular morbidities. There is subcutaneous fat, if you can see. Now the DEXA has also parameters for visceral fat amount. So newer DEXA machine like Hologic, GE Lunar, they have got softwares like Core Scan or Inner Core, which helps in measuring the subcutaneous fat also. And they say that the VAT more than 100 centimeter square is associated with adverse metabolic outcomes. One of the studies, they said even this VAT more than 17 centimeter square in women predicted metabolic syndrome with higher sensitivity and specificity. In some cases, they say even the SAT more than 204 centimeter square is associated with better predictor of metabolic syndrome and its complications in men. Then there is another part of the analysis report, percentage fat for the young normal and adult mean. So differential fat distribution is important. Sometimes it may happen the trunk has got more fat, the limbs has got less. If you see here, the trunk fat percentage is okay. Body fat is normal, 22.6%. However, if you see the limb fat, it is less. So this can give us clue regarding various type of lipodystrophy syndromes. This was a case of basically LMNA or partial lipodystrophy syndrome type 2, Dunning-Hen type. So this also gives clue regarding this thing if you do advanced analysis of fat in the body. In HIV also it has been seen that there is certain drugs which cause lipodystrophies. So the trunk fat to lower limb mass ratio, if it is more than 2.28, it has shown development of lipodystrophy and metabolic syndrome. Also, it is useful for diabetes, especially in nephrotic syndrome, development of fatty liver. And in such cases, if we come to know these things, then we can use certain drugs which are contraindicated in diabetes per se, like pioglitazone, but they can be used in such situation because they may improve this part. Another beneficial aspect is sarcopenic obesity. We know that more and more people are diagnosed with sarcopenic obesity, which there is either muscle mass is low, the muscle strength is low, or they have got less function. So here we take into consideration the lean mass index. As I mentioned earlier, it should not be less than 7 in males or not less than 5.4 in females. It should be more above that. So if you see this patient, body fat is 42.2%. FMI is elevated 11.1%. And appendicular lean mass, appendicular skeletal soft skeletal muscle mass, which should be above 6 kilogram per meter square. Here it is 5.86. So it becomes a case of sarcopenic obesity. It is not only obesity, but there is additional component of muscle wasting is also there. Muscle loss is also there. At the same time, if you see here, here also appendicular skeletal muscle mass is low. However, total body fat is normal. So this comes in the rare syndromes, neurological syndromes like facioscapulohumeral dystrophy syndromes, where there are certain abnormal parameters that we can get into picture. Coming to other methods like CT scan, as I mentioned earlier, it also gives advantage of visceral adiposity, muscle mass. Hepatic fat content can be identified by both CT scan as well as MRI. And the functional imaging like PET scan, which in addition to gives the functional aspect also like brown adipose tissue also. So you should be aware of these things. So body fat analysis is not only percentage body fat. If you go into depth, you'll get more and more details regarding how you can go about it and what all syndromes, not only endocrinological, neurological, as well as metabolic syndromes, which can be assessed by these methods. So this is typical example of body fat analysis by CT scan. If you see the pink brownish structure is shown is subcutaneous tissue, whereas the visceral adipose tissue is seen here. And it also has only thing drawback with this technique is, as you know, the radiation hazard. So it is not commonly used, only used in research settings. Similarly, MRI. MRI also has shown, if you see here, the water content can be analyzed. It can show basically the fat mass. If you see the subcutaneous tissue, visceral adipose tissue, and the muscle mass. So entire body with the fat and percentage can be calculated. However, as you know, the technique is laborious. It takes long time. Difficulty in children because of the movement associated artifacts. So these are the most of the techniques that have been used for assessment of body fat analysis. What is new? New is everywhere you know artificial intelligence. So even the AI is being used in body fat analysis. Since CT MRI is used, so radiology, which is as such is a current modality in which maximum AI is used, same thing are used for this purpose. AI, if combined with these imaging modalities, helps to assess and analyze these parameters, and directly it will give you result. It can also do automatic segmentation by deep learning using convoluted neural networks to determine the quantity of the fat, the muscle mass, and direct interpretation also can come into picture. However, the limitation of AI should be man behind the machine that they say. Similarly, there are certain limitations. Study population which is used to develop those algorithms are important, because if the populations are heterogeneous, then it may affect errors. Sampling bias may be there, and it may not be generalizable to say Indian population versus Caucasian populations, male versus female, extremes of age. However, there are certain bias mitigation strategies. Like when you use the models, you have to use diligent data preparation, train the model effectively, do frequent analysis and fine tuning, evaluate, re-evaluate before you get that model into practice for interpretation in real world situations. Newer modalities like generative AI has come up and it has shown that convoluted neural networks, if used in supervised manner, can be useful for biomarker segregation. There are opportunities even in unsupervised learning where labeled data is challenging to obtain. In such cases, you can use unlabeled data also for unsupervised learning purpose. Recently, I have come across one Chinese study in which you take the photograph of a person, use the AI, and it can give the percentage of body fat. So the accuracy may not be that great, but it is being used often in most of the wellness apps, body weight reduction, obesity related follow-up patients in various gymnasiums. It is being used in Chinese population. And it has got smartphone correlation as part. It is certain apps are being developed for weight loss programs also with this. So that's all from my side. I'll conclude my talk by saying body fat analysis is essential for nutritional status, obesity phenotype, and to look for the analysis, follow-up of patients when we either treat either by neuromodulation, diet modification, use of GLP analogs. Various techniques have been enumerated. Some you can follow up and try to use in your clinics also. Positioning and pre-test precautions are must. You have to consider what is your clinic size, what is your aim, whether it is research, so how much accuracy is required, how much you can afford, and what is the technical manpower that you are having with you. And in future, AI will be inevitable. Thank you, ladies and gentlemen, for giving me a patient hearing. Thank you.
Thank you, sir. We truly appreciate your insights on body fat analysis. Now, I would like to invite Dr. Vaishali Deshmukh ma'am on stage. She is an organizer of SYNAPSE 2026 and an endocrinologist. Requested ma'am to come on stage.
Now I'm going to talk on behalf of Abbott, and this is a contracted talk for Abbott. So I'll be speaking on a very important topic of subclinical hypothyroidism in the current era of metabolic syndrome. So, what is the link, and what is the way to go ahead when we are dealing with both these together in a patient? So, uh, I begin with a case. Now, this is a 42-year-old woman with already taking thyroxine, and she's been on treatment with statins. She's undergone angioplasty. She's had blood pressure which has been on the higher range, and you can see that the patient's BMI is around 31. She has impaired glucose tolerance and does have dyslipidemia. So this is a classic patient that most of us as endocrinologists or physicians encounter in our practice. And if you have to see that this patient's TSH is still on the higher side, and it is around 12 international units per ml, and the T3, T4, and TPO is negative. She was diagnosed with metabolic syndrome and was partially treated hypothyroidism. So we know that both these disorders are increasing in India, and India is undergoing a transition from iodine deficiency to sufficiency, and autoimmunity is also on a rise. We know that the era of iodization, there has been worsening of autoimmunity. Prevalence of hypothyroidism in India is in the tune of 10%, with the addition of nearly 8% being subclinically hypothyroid. So, undetected hypothyroidism is known to give an important, pose an important challenge, and approximately 3.5% of Indians have undiagnosed hypothyroidism. So, you can see that the burden is huge. Why it is important to understand is because thyroid dysfunction is one of the important cardiovascular risk factors. So you can see that cardiac function, the electrophysiological activity, the renal effects, the metabolic effects, and also the cardioprotective effects depend on the thyroid function status in a particular patient, and that is why having a euthyroid status is very essential when we are talking about cardiovascular protection. Now, hypothyroidism is one of the important risk factors for worsening of diabetes, and you can see that diabetes, hypertension, dyslipidemia, as well as NAFLD, the MASLD, is very common in hypothyroidism also and in metabolic syndrome also. So, there is a common link which joins these two conditions, and that is how the cardiovascular risk is conferred because of this. So, metabolic syndrome and hypothyroidism is associated with each and every component. So, all hypothyroid patients face issues with abdominal obesity, hyperglycemia, or impaired glucose tolerance, hypertension, dyslipidemia, or fatty liver disease. And if you see the criteria for diagnosis of metabolic syndrome and the risk factors for metabolic syndrome and CV risk, they are nearly multiplier of each other. So when you're talking about increased waist circumference, fasting sugars being high, BP being high, triglyceride being high, LDL being low, all these are also encountered in patients with subclinical hypothyroidism. The risk of metabolic syndrome is double as far as the cardiovascular dysfunction is considered, and most predictive components of cardiovascular disease are the blood pressure and the HDL component and the waist circumference. But when we are talking about hypothyroidism also, we encountered all these three problems very commonly. So we do see that all these subclinical and clinical hypothyroid patients are having a increased waist circumference. They do have elevated blood pressure, and there is an increase lowering of HDL levels. So association of both these are very commonly seen with each other. Abdominal obesity, the prevalence of hypothyroidism, you can see that 1 in 5 morbidly obese patient is hypothyroid. Then 1 in 2 hypothyroid patient is abdominally obese. 1 in 3 hypertensive patient is hypothyroid. 1 in 4 diabetic is hypothyroid, and 1 in 4 dyslipidemic is hypothyroid. Now, whether it is coincidental coexistence of both or it's a causative correlation, there is a long research on this which goes on, and that tells us that both are interlinked in some fashion or the other. Similarly, dyslipidemia and hypothyroidism are both are multipliers of cardiovascular risk. So, if you see a patient of dyslipidemia individually and hypothyroid individually, and you take a patient with both, the person with both are definitely at very high risk of cardiovascular disease, especially when the LP little a levels, in the Indian context, if I have to speak, that is very commonly seen as a co-additional factor, and hyperhomocystinemia, again related to B12 deficiency and metabolism, 1 carbon metabolism defect, is also very common. So you can see in the Indian context, you have still multiplication of multiple factors, the TSH, the lipids, the LP little a, and the hyperhomocystinemia, and so on and so forth. So hypothyroidism induced NAFLD is also one of an important oxidative stress factor which responds to this worsening of hepatic insulin resistance and becomes a causative factor for the cardiovascular disease. So again, if you have to see that patient with NAFLD have a significantly higher level of having TSH. See, initially when I passed my DM, I was told that when a borderline high TSH is there and the antibodies are negative, you need not treat that because there is no need to treat a borderline high TSH. But now we know that the mechanism of this borderline TSH is also linked with the oxidative stress and various pathways which are known to affect metabolism, and this is known to be one of the risk factor for cardiovascular disease. So it is important for us to think of getting a euthyroid status even in these patients. You may not need lifelong therapy for them, like you advise for autoimmune thyroiditis. So it is a reversible form of hypothyroidism into brackets that we see these days. And I think that is what we are seeing more common than what we used to see previously as autoimmune thyroiditis. So the association between subclinical hypothyroidism and metabolic syndrome is a very significant association, and lot of literature is available on this. Nearly 80,000 participants in various studies have been studied, and they found that the odds ratio of cardiovascular disease and having metabolic syndrome was nearly 1.2. So it means that there is a 25% higher risk of having any metabolic syndrome parameter when you have subclinical hypothyroidism, and mainly in the form of central obesity, hypertension, triglyceride and LDL level. So if I go to the through the studies, I'll just read the topics and the conclusion just to not confuse you. So the prevalence of thyroid dysfunction in metabolic syndrome was studied, and what was the conclusion? That thyroid dysfunction and metabolic syndrome are interlinked, and it is necessary to evaluate all metabolic syndrome patients for thyroid disease. In fact, any patient with hypertension, cardiovascular risk, IHG, AMI or post bypass need to have at least a TSH done once in their lifetime so that you can diagnose and treat them appropriately. So it is, why is it so important? Because it's one of the modifiable and very important modifiable risk factor. It's easy to treat, easy to diagnose, and it has been proven that thyroxine therapy is known to reduce the prevalence of hypertension. At least it is known to be one of the factors for vasodilatation, improves the glycemic control and the dyslipidemia. So it has been found in various studies in meta-analysis that thyroxine is known to reduce the blood pressure in patients with subclinical hypothyroidism. How much is the blood pressure reduction? You can see the tune of 4 by 2. 4 by 2 is a significant reduction when we are talking about reduction in the cardiovascular risk. And that is why it is because there is improvement in the vascular function, reduction in the peripheral resistance and improve endothelial dysfunction that helps in reducing the BP. Secondly, as far as the sugar control is considered, again there is data to suggest that there is a HbA1c reduction, and in the treatment arm you can see that in patients with impaired glucose tolerance, the normalization of HbA1c vis-a-vis the ones who were not treated is being seen. And these subtle abnormalities, if you add on each of these subtle abnormalities, the cardiovascular risk is going to multiply every now and then, and that's why it's important to treat each and every factor. It is also known to reduce the metabolic parameters like HbA1c, fasting glucose, and 2 hours postprandial glucose in various studies. Similarly, what happens to the lipid profile? It becomes more favorable. So there is a reduction in total cholesterol, triglycerides, and LDL-C, very significant statistically, and improvement in the HDL within 6 months of therapy with subclinical hypothyroidism. So now, whether TSH becomes a marker of metabolic syndrome is a second question. I'm sure that soon it will be added up. Like yesterday, we heard that uric acid is now included into the metabolic syndrome guidelines. I'm sure that borderline high TSH will soon take its place into metabolic syndrome, seeing the data that is available. So subclinical hypothyroidism patients could benefit from thyroxine therapy to improve their lipid profile, and regardless of the basal thyrotropin or total concentration of cholesterol. So hypothyroidism, is it a factor for cardiac disease alone? Yes, there has been data to suggest, and we know the link between thyroid and cardiovascular disease. We know that there are a lot of vascular parameters which are hampered in patients with hypothyroidism. So you can see that they do have systolic and diastolic dysfunction, they have endothelial dysfunction, they have obesity, metabolic syndrome, they have vascular abnormalities, they do have anemia, and they do have other parameters which are abnormal. Now, what is the association between cardiovascular events? So, this was a meta-analysis of nearly 18 lakh population which was done, and they found that the IHD risk, the myocardial infarction risk, the cardiac mortality, and all-cause mortality was higher in patients with subclinical hypothyroidism. So, it is we initially we were taught that you treat with thyroxine, you worsen cardiac disease. But if you see subclinical hypothyroidism in the current context, being borderline hypothyroid is one of the important risk factors for having cardiovascular disease. So there needs to be a judicious thought in normalizing or optimizing the thyroid level in every patient with cardiovascular disease. So it is an independent risk factor for cardiovascular disease, and when we are talking about CV risk, the need for treatment of all the hypothyroid patients is mandatory. Now, hypothyroidism also determines the clinical outcome. So, in patients with cardiac disease, they found that if you have a euthyroid cardiac patient vis-a-vis a hypothyroid patient, there is an independent benefit of treating, and the cardiovascular event rate was much lesser when patients were euthyroid. So, in short, we try and optimize all our cardiovascular and metabolic syndrome and obese patients. So, I see a lot of prescriptions where a lot of endocrinologists say there is no need to treat the TSH of 6 and 7. But when we are thinking in terms of metabolic syndrome, obesity, and patients with high CV risk, it is always preferable to optimize them to the TSH of normal range, that is between 1 and 2. So, post effect of thyroid therapy, thyroxine therapy on the intima media thickness, we know that carotid intima media thickness is one of the parameters for cardiovascular disease, and a lot of studies have been done in this aspect, and they found that there is an association between increased carotid intima media thickness in patients with subclinical hypothyroidism. So they do have increased atherosclerotic tendency, and treating that is known to improve the CIMT and at least try and keep the TSH below 10. Now, ideally, if you talk in terms of the literature available for dyslipidemia, you go as closer to 1. The TSH level as closer to 1 gives you more optimization of lipid control as compared to this. And it is important to screen all the patients with early signs of thyroid dysfunction, especially when you have atherosclerotic patients. So any patient whom you think is at metabolic syndrome risk or obesity, we are here on the obesity forum, they need to be screened for thyroid dysfunction as one of the important parameters. And replacement therapy is important, especially it has been proven to show a reversal of this thickness of carotid intima media thickness, which is one of the risk factor also for the cerebrovascular disease. So, what about the morbidity and mortality risk reduction? So they found that benefit of thyroxine therapy in reducing all-cause mortality, cardiovascular mortality in younger population. We know that as Indians, we are seeing a lot of younger population with high CV risk, and the 8-year period observation in 40 to 70-year-old has proven that there is a reduction in all-cause events related to the heart and reduction in the IHD risk in these patients. So there is a benefit of screening early patients for hypothyroidism because the consequences of untreated hypothyroidism are significant as far as the cardiovascular disease is considered, and prevalence of metabolic syndrome is rising in children as well as in adults, and I think that in such a population, if you are going to benefit in optimizing the thyroid level, the outcomes are going to be much better. So what are the consequences if you don't treat it? So if you don't treat it, there is a worsening of cardiac output. Hypertension worsening is there. There is increase in the abdominal girth, dyslipidemia, and cardiovascular disease burden. And of course, the mortality risk increases. Now, it is important to realize that thyroid hormones are cardioprotective also. So, what they do is they reverse the atherosclerosis, they lower the peripheral vascular resistance, they improve the myocardial perfusion, they improve the lipid profile, and the dysfunction, the diastolic as well as systolic dysfunction of the heart improves with thyroxine. So every thyroid patient and every metabolic syndrome patient needs to see that their thyroid status is under good control. So when we are talking about Indians and Asians, CVD strikes Indian a decade earlier. So we are having cardiac disease a decade earlier, we are having obesity a decade earlier, we are having diabetes a decade earlier. And that is why this population needs a treatment and a cocktail of treatment for improving the risk of the cardiovascular disease in this category of population. So especially in when the prevalence in Indians is less than below 40 years is nearly around 18%. So this is the subclinical hypothyroidism prevalence, and equal is the amount of metabolic syndrome. It is wise to look for TSH abnormalities in this. So early recognition and treatment is essential. So what we need actually is an integrated approach. Why we are discussing this on this forum is because we need early screening of all metabolic syndrome for hypothyroidism. We need to move beyond one size fit all. So they have to be, again, in hypothyroidism also we are now talking about individualization based on risk therapy. And we need to look into treating these patients with statins, antihypertensive, anti-diabetic agents, and thyroxine along with this. There needs to be some assessment. We spoke on nutrition yesterday, but iodine deficiency, selenium deficiency is a big problem in overall nutrition. So we need to talk about these in terms of thyroid health also. And stress, we know that thyroid hormone is an important responder to stress. So when we are talking about any metabolic stressor, we need to see that thyroid hormone needs to be normalized, and holistic management of metabolic syndrome should also encompass thyroid assessment. And precision medicine is important when you are talking about genomic profiling, and there are a lot of digital health tools which also help in remote monitoring. So if you have to revisit this patient, the BMI reduction was easier after the dose was up titrated, the blood pressure reduction was better. You can see slight improvement in the glycemic status, improvement in the lipid. So though they are not drastic, put together all these factors, they are known to benefit the cardiovascular risk. And as you get the TSH normalized closer and closer to the 1 to 3 range, you can see that lipids are still better. The parameters improvise still better, and patients still have a better quality of life. So, if you have to take the take home messages for today, the hypothyroidism and metabolic syndrome are deeply interconnected, and one increases the other's risk. So, both can impair each other. So, early screening and integrated management is required. You need not see, as far as the Western population is considered, they see a lot of autoimmune thyroid disease, but we are seeing a lot of metabolic syndrome with subclinical hypothyroidism, and we are not behaving the same as the Western population. So we need to think for our population base to reduce the cardiovascular risk. So I thank you for all the patient listening, and we'll take the questions at the end. Thank you so much.
Thank you so much, ma'am, for sharing your expertise. Now, I would like to invite Dr. Rahul Samant. He has completed his MBBS from Bharati Vidyapit Medical College, MD from Sassoon General Hospital, MRCP and CCT in Cardiology from Royal College of Physicians in London, FACC from American College of Cardiology, Medical Officer at PHC Chandansar, Resident MOICU at Pune Institute of Neurology, Lecturer in Medicines at Sassoon Hospital, Interventional Cardiologist at Dinanath Mangeshkar Hospitals from 10 years. I would like to invite Dr. Rahul Samant sir on stage.
Thanks for giving me an opportunity to speak on this august platform about newer drugs in hypertension. Uh, you all must be treating hypertension, and it's quite a regular treatment schedule for general practitioners to super specialists. You all must have come across people who are hypertensive, getting treatment with standard drugs, but still not getting controlled. And at these times, these patients are referred to specialist hospital or super specialists like us for controlling blood pressure, and still their blood pressure is not under control. So what's going on? Despite having so many different drugs, why it's not getting controlled? So the research goes on, and now we have a new drug which will be coming to India, which is aldosterone synthesis inhibitor, aldosterone synthase inhibitor. So we'll talk about it. As you all know, the hypertension is a very big problem worldwide, and I love managing blood pressure patients because this is a simple thing you can do is treat their blood pressure, and that's going to reduce the morbidity and mortality and reduce the burden of the disease on the entire population. So blood pressure is so common that 1.4 billion people in the world suffer from high blood pressure. Around 50% of these people do not know that they have high blood pressure, and that's why it's important to raise the awareness amongst the masses about high blood pressure. Blood pressure is a silent killer, and if you don't diagnose or treat blood pressure, huge number of people will die of heart attack, heart failure, kidney failure, stroke, and that becomes a problem for the country as well as the family. So as you know that aldosterone is very important in normal physiology. You all have learned about renin, angiotensin, aldosterone system, and there are different drugs which are available which act on this axis. So aldosterone is synthesized in adrenal gland, and adrenal gland has got three layers. The topmost layers manufactures or synthesizes aldosterone. And this aldosterone, which have been blocking using mineralocorticoid receptor antagonists, MRAs. MRAs have been in place from 1960s, and we are using MRAs as a second line of antihypertensives. So we have other drugs like ACE inhibitors, angiotensin receptor blockers, calcium channel blockers. We have diuretics. We have beta blockers, alpha blockers, centrally acting sympathetic blockers. So we have so many different drugs, but still about 20% of the patients do not have control of their blood pressure. The prevalence is increasing globally, maybe a number of reasons, which include their lifestyle, the quality of life, the stress, the diet, lack of peace of mind because of various reasons, and probably genetic reason as well. So as the urbanization grew, the hypertension grew. So hypertension is not only prevalent in India or Indian subcontinent, it is prevalent all across the world, including China, United States, UK, Germany, everywhere. So we need a excellent program to manage the hypertension. I like hypertension management, as I said, is because managing hypertension is very easy. You just give the tablet and patient will live a normal life. As against diabetes management is very complex. You have to keep monitoring all the time, and this one intervention of giving some medication is going to normalize the life of the patient and will give a normal life longevity to that patient. Even when adherent to multiple antihypertensive medication, patients of hypertension remain uncontrolled, and these are the people who are challenging patients. Most of these patients are, as you would realize, that they are obese, they have got a renal disease, they have some dietary factors which you are probably not aware. They may be coming from a different race like Afro-Caribbean race where the hypertension is quite resistant to treat. As a result of these resistant hypertensives, you must have seen here in Pune as well. So these resistant hypertensive patients will land up eventually into kidney failure. They will go on dialysis. They will have strokes. They will have more incidence of myocardial infarctions. And this causes a major problem for the hospitals, patients, as well as the nation. So burden of hypertension, prevalence of hypertension is around 22.6% in India. And it's a very, very common problem which people are absolutely not aware. Most of the people, I do a lot of BP campaigning in the month of May. I am part of May Measurement Month campaign where we randomly check patients for blood pressure for free in the month of May in our public places. And what we found is even in Warkari, pilgrimage, we do BP measurement campaigns. And what we found is number of patients do not have idea that they have high blood pressure. And once you tell them that they have high blood pressure, they are very reluctant to accept that they have high blood pressure. The reason is they are not having any symptoms. So we need to raise the awareness. India has huge prevalence, as mentioned here, burden of uncontrolled hypertension and resistant hypertension. So those people who are uncontrolled and despite medication, I'll come to the definition of resistant hypertension, but those resistant hypertensives are a further problem, which is around 20% of the population. So as this slide says, how do you define resistant hypertension? Resistant hypertension, as per the 2025 ACC-AHA guidelines, is the people who are not getting control despite more than or equal to 3 antihypertensive medication. That's office BP more than 130, more than 80 millimeters of mercury. That's the American criteria. Americans are a bit more strict on blood pressure compared to Europeans. And other definition is office BP less than 130 by 80, but using more than 3, that's 4 antihypertensive. That is also called as resistant hypertension. Similarly, as I mentioned, the European Society and ISH, International Society for Hypertension, mention about 140 by 90 as the recommended therapy. More or less, the guidelines are same. If you are using more than 3 antihypertensives, then you are considered as a resistant hypertension. And here in India, if you see in your clinical practice, most of you are using some ARB or ACE. You are using CCB, and you are using diuretic. So these 3 antihypertensives are very much commonly used. At least 20 to 30% of my patients will be on at least 3 antihypertensive medication. At least 5 to 10% in my clinical practice will be having very difficult to control high blood pressure. So this is the prevalence of resistant hypertension in India. If you see, there are a number of studies from different locations, and you see that, as I mentioned, around 15 to 20% patients remain hypertensive. Obesity, as this conference is focusing on the general metabolic health, obesity remains a very common problem. And I think the arrival of semaglutide has helped to curtail patients' hunger and craving, but you cannot give semaglutide to everyone. I think the population has become mentally sick that they want to go and indulge into some sort of a addictive behavior. And I think food is a very addictive behavior. People blame alcohol, smoking, and drugs, but food is also equally addictive, and that has created huge problem worldwide. Excess availability is another problem. I'm sure people were addictive to food long time back as well, but the food availability was not that great 30, 40 years back. But now the food is available in abundance, and the drive is there, so that's why people are becoming obese. But as a result of obesity, these people are resistant to treat their hypertension. So leptin plays a role here as well. So we know from the SPRINT and ACCORD trial that if you lower the blood pressure significantly, that the targets in SPRINT and ACCORD, where it was the intensive blood pressure treatment trials, if you lower the BP like 120 by 80 to the level, then you can reduce the CV events further. So 25% and 41% as per SPRINT and ACCORD BP data. So this is what the Americans do. They want to reduce the blood pressure significantly. Also, I would like to highlight that in your clinical practice, don't reduce the blood pressure too low as well. Now, some patients come with a BP of 100, 110 systolic. So doing that also is not good, because it follows a J-curve pattern, and as a result of lowering blood pressure too much with antihypertensive is also going to increase the number of events, cardiovascular events. So most of the BP controls are similar. As you can see on the left side, there's a systolic blood pressure of at least 130, and 120 to 130 is acceptable, and diastolic BP of target of 80. That's a class 1 recommendation from European Society as well as AHA. So we have a consensus that blood pressure should be anywhere around 120 to 130. Okay. And diastolic should be around 80 to 90. That's what all the guidelines have said, more or less over a period of time. As you know, that hypertension is a complex condition and may be caused by diverse range of drivers. And since we are in medical school, we had few drugs. At that time, ARBs were not available. We just had, chlorthalidone, hydrochlorothiazide. Then we had ACE inhibitors had just come in 1990s, and then came the ARBs. Amlodipine and nifedipine were hugely available then. And then over a period of time, you have new drugs which have evolved. So what we do in the, let it be diabetes or heart disease or platelets, there are multiple mechanisms by which the disease develops, and the different mechanism need to be controlled. So what we know is, as I already alluded to, like calcium channel blockers, renin-angiotensin-aldosterone system, central sympathetic nervous system. But there are other mechanisms like aldosterone, which was not addressed so far because no drug was available. Now we have a drug for that. There are other mechanics which are not really managed yet, which is endothelial dysfunction, small artery remodeling, large arterial stiffness. I think the exercise is the biggest driver here, which can modify these micro environment of the body. So behavioral factors, as mentioned on the right side of the screen, that's these behavioral factors play a very important role. And if we using the mind body, we need to correct the behavior of the population. Unless you correct the behavior of the population, number of drugs will not help. I think really where the drug helps is where the patient has done all these things and still patient is not controlled. So all our patients need to undergo lifestyle measures as the primary treatment besides their medical treatment. So aldosterone is a under-recognized driver of hypertension. As I mentioned, that aldosterone is synthesized in adrenal gland, which is a small gland located above the kidney. Aldosterone exhibits two types of actions. It's through the MR, which is mineralocorticoid receptor, and non-mineralocorticoid receptor action. So what we are doing with MRAs is we are blocking these receptors, but not actually blocking the aldosterone. And what it leads to is the effect of, because we are blocking the receptor, the aldosterone level will go up. And when the aldosterone level goes up, actually every action is not mediated by receptor, mineralocorticoid receptor. So some actions will be direct effect of aldosterone, which I'm not very sure about how this actually acts, but these are called as rapid non-genomic effects, and these non-genomic effects will lead to basically inflammation and fibrosis. Fibrosis will happen in all the vital organs like kidney, which will lead to interstitial kidney disease. It will lead to myocardial fibrosis. It will lead to endothelial dysfunction and damages the organs. So as we know that this entire thing is as a result of inflammation in the body, and what lifestyle measures, yoga, pranayam, everything does is reduces the inflammation in the body by calming the body. It reduces the inflammatory markers. So aldosterone dysregulation is prevalent in patients with hypertension. 30% of patients with hypertension may have aldosterone dysregulation. And as mentioned, that obesity, type 2 diabetes, sleep apnea, hypokalemia, resistant hypertension, all these areas are responsible for aldosterone dysregulation. So association of aldosterone with hypertension. So you see that higher levels of aldosterone are positively correlated with increase in the blood pressure, both systolic as well as diastolic. So if you look at the aldosterone levels in these patients as per the severity of the hypertension, the resistant hypertension, treated resistant hypertension patients have the maximum level of aldosterone levels. So that means aldosterone is responsible for these actions. So as I discussed already, that this aldosterone is toxic to the body. It is going to cause inflammation in all the organs. It is going to increase the fibrosis, increase myocardial events, strokes, and we need to control this aldosterone with some drugs. This aldosterone is responsible, or increased blood pressure is responsible for hypertension, and resistant hypertension is responsible for increased atrial fibrillation. As you must have seen in a lot of these patients, how atrial fibrillation is very, very higher proportion compared to normal population. They have coronary artery disease, heart failure, and strokes. So this is the result of uncontrolled hypertension. Patients with aldosterone dysregulation are at increased risk of proteinuria, CKD progression, and end-stage kidney disease. I treat a lot of these resistant hypertensives because once they are done with their GP and GP is not able to control their blood pressure, then they are sent to either the nephrologist, endocrinologist, or cardiologist for management of their blood pressure. And you see that these patients are very difficult to control. Their kidney function is initially normal, but if you do their proteinuria over a period of time, you will see that they start gradually developing microalbuminuria, and then eventually over a period of 1 to 5 years they start developing kidney failure. And then you realize that yes, this is the reason that this guy was having a difficulty in controlling his high blood pressure. So currently our intention was to control this by using only currently available medication, but now we have this aldosterone synthase inhibitor, which basically acts on specifically on aldosterone synthase, which is very specific to synthesis of aldosterone. It does not affect the cortisol synthesis. So this is really a breakthrough, and it will give us another tool to control these resistant hypertensive patients. So effects of antihypertensive medication on aldosterone. So you can see that when we use ACE inhibitors, ARBs, CCBs, their aldosterone is actually going to go up. And you see that maximum rise in aldosterone is seen as a result of use of MRAs or thiazide diuretics. And when this free aldosterone is higher, it's going to lead to organ damage. So we have this specific drug which is available. It's called baxdrostat, which is a first-in-class drug available in United States. It's not available in India as of now, and there are 2-3 more similar drugs from the same class will be available in future also. But currently, the only drug which has got a license for treatment of hypertension is baxdrostat. So briefly go through the drug. So baxdrostat, as I said, is very selective in terms of blocking the CYP11B2, which is aldosterone synthase activity, and as a result of that, it causes reduction in aldosterone level. This cortisol production is through CYP11B1, which is 11 beta hydroxylase, which is a different enzyme, so that doesn't get affected, and it's got a high selectivity, is 100 to 1 selectivity, so it's very selective. So the advantage of this is there's no effect on cortisol, but only effect on aldosterone. So there are a couple of trials. BAX hypertension study, which was basically a complex design. But what they have done is they have looked at the placebo, and they have taken in consideration 2 doses, which is baxdrostat 1 mg and 2 mg. And over a period of time, they have found that use of baxdrostat 2 mg is going to reduce the blood pressure significantly. So I'll go through the results. So these are patient demographics. You can see that most of the patients are around 60 years of age. Around 60% of the patients are males, and the GFR is around 80. And you can see that the patients with 1 mg are around 149, 2 mg, and this is the resistant hypertensions were around 70%, uncontrolled hypertension 30%. That's their baseline criteria, how these patients were recruited. Baxdrostat demonstrated significant placebo-corrected reductions in seated systolic blood pressure and diastolic blood pressure in patients with uncontrolled or resistant hypertension. So what we found is around it's a double-digit reduction in blood pressure. If you look at the major BP trials, most of these trials will give you blood pressure reduction of 6 millimeters of mercury for systolic and about 3 to 4 millimeters of mercury for diastolic. But here you can see that the reduction in the blood pressure is very significant. It's in double digits. And at 12 weeks, you could see that there are around 15 millimeters of mercury is the reduction in the blood pressure. So baxdrostat demonstrated significant placebo-corrected reduction in seated systolic blood pressure in resistant hypertension subpopulation at week 12. So what we believe is this drug is going to be very, very useful in this group of patients where you have a resistant hypertension. So this is another trial, which is BAX24 trial. Basically, this looked at the lowering of blood pressure at ambulatory BP. And you can see here that ambulatory BP was also significantly reduced in these group of patients. So, common issue with the hypertensive patients is their nighttime BP. You must have heard the term called a nighttime dipper. And nighttime dipper people are less likely to get an event compared to people who do not dip their blood pressure at nighttime. And here, in Pune, they play DJ at midnight, last night or every night. And what happens is, as a result of this noise pollution, your BP doesn't drop at night. And then people keep saying why people in Pune are dying more of heart attack and stroke and death or cancer. The basic reason is how the population behaves. And most difficult control to think is the behavior of any population in any country. So, doctors are usually sidelined from political side because they don't want people like us to talk. And what happens is, as a result of this last 20 years, you must have seen that number of deaths as a result of cancer, as a result of heart attacks, strokes, and kidney failure have increased significantly. So, people have to drop their blood pressure, heart rate, and sympathetic drive at night. And usually this will happen between 2 to 4 a.m. or 2 to 5 a.m. And what they found in this setup is the 24-hour and nighttime systolic BP reduced significantly after using of Baxdrostat. So this is Baxdrostat 2 mg phase 3 trial. So the systolic blood pressure was significantly reduced, as well as diastolic blood pressure was significantly reduced as a result of use of Baxdrostat 2 mg. The proportion of treated patients achieving 24-hour systolic blood pressure target less than 130 was significantly higher compared to placebo. So you can see the graphs where there's significant reduction. Baxdrostat achieved significant placebo-corrected reductions across systolic BP endpoints at week 12. So you see that 24-hour ambulatory BP around 14 millimeters of mercury, nighttime BP around 13.9, so around 14 millimeters of mercury day and nighttime, and seated BP around 10.3 millimeters of mercury. So in terms of side effects, any new drug comes to the market, people will be worried about side effects. So as you know that it's like MRA only, but the side effects profile is going to be like that. So people are going to get hyperkalemia. So Baxdrostat 2 mg versus placebo. So 7 people got hyperkalemia, hyponatremia 1 person, and hypotension 1 person. So hyperkalemia was the side effect. So we'll have to watch out for hyperkalemia and hyponatremia. There are otherwise no significant side effects apart from that. So both these trials, Baxdrostat decreased serum aldosterone levels in BAX hypertension and BAX 24 trials. So in summary, close to 80% of the people with hypertension are not at goal, and if not adequately controlled, could be at increased risk of CV events and mortality. So we need to, as a physician, general practitioner, we need to focus on diagnosis and basic treatment. Inhibition of aldosterone synthase with Baxdrostat leads to decrease in BP and may protect against end-organ damage. So we have to, all these specialist centers, we need to have where resistant hypertension is being treated, and we should have availability of this drug sooner the better. Currently, people try to use ARNI class of drugs, but ARNI is not, ARNI was tried for resistant hypertension, but it didn't work, and that's why it came to heart failure. But some cardiologists do try, including myself. When nothing works, we do try ARNI, but it is not officially, licensed for that. And in BAX hypertension trial, Baxdrostat demonstrated significant placebo-corrected reduction in seated SBP and DBP in patients with uncontrolled hypertension as well as resistant hypertension. So this drug is going to be pretty effective, and the side effect profile is not much. Only thing we'll need to do is monitor their potassium, sodium on a routine basis. Again, patients with renal impairment will have to be careful about. Patients where they are going to, their potassium intake will have to restrict if they are taking Baxdrostat. I don't know what will be the cost of the drug because it's not launched in India, but I'm sure it will be like any other newer drug which comes to Indian market. Any questions?
Yeah, thank you, Dr. Rahul sir. We'll call all the speakers of the first session for a discussion.
One is that with the metabolic syndrome and with metabolic syndrome
and subclinical hypothyroidism, we generally, the thing is that we know that there is, with obesity or metabolic syndrome, there is going to be a TSH rise. Most of the times we get it. And they may be TPO and TG antibody negative, most of these patients. So are you saying that we must treat them to bring down the cardiovascular risk despite them not being truly hypothyroid? And how long should we treat them if we want to? Because we don't know how, this is not permanent hypothyroidism in most cases, although some false negative may be there in the antibody levels. But then if, maybe it's 7 TSH and metabolic syndrome, I'm very, very convinced that this is due to the obesity itself. Now, should I treat that TSH and how long?
Okay, so I can share the data that we have done. We've done study of metabolic syndrome and subclinical hypothyroidism prevalence in patients with hypertension, and the figures were very significant in the Indian context. Now, a second study which I have done as my part of my thesis, we have done screening of 236 menopausal women, and we found that prevalence of subclinical hypothyroidism is very high, and irrespective of their antibody status, they had that subclinical hypothyroidism. I had the privilege of doing a RCT for 6 months of therapy versus no therapy, and we found that the therapy benefits for all the we had done intervals, the cardiac intervals, they were benefited in terms of a positive direction of benefit, and the lipids also improved significantly. So this is my own experience that I can talk about. Regarding literature, now what I feel is that literature is very inadequate in terms of defining the Indian type of subclinical hypothyroidism. So we need to, as Indian endocrinologists, we need to have our own data on how it directly affects the heart. But I think it is a co-association rather than a causative direct effect. But we have seen in clinical practice the reversibility of that subclinical hypothyroidism is significant with lifestyle changes. So the moment the weight comes down, that's why I never tell my patients that you have to take treatment lifelong, because I have seen in clinical practice that the benefit of weight loss, diabetes control, blood pressure control translates into improvement of thyroid deficiency. Now, having said that, there is a lot of literature to say that the TSH being on the higher side is a cardiac risk factor. So you have to optimize the TSH level is final conclusion that I would come through with all this that we have gone through. So the initial rejection that you should not treat all subclinical hypothyroid, I don't think is right in the current context of literature. You need to get the TSH to the level around 1 to 3 so that you optimize the cardiac risk to the minimum. So I think I leave the decision to individualization again. So even in thyroid, we have to come to this point that we have to individualize therapy. Maybe Anish and Dr.
I have different perspective on this. I'll suggest younger patient we should treat. Elderly we should be cautious because it might affect their bone metabolism also, osteoporosis related. That is my personal take view, sir.
Partly, I would agree with both of them that maybe if I have a patient with subclinical hypothyroidism who already has IgD or is very high risk of cardiovascular risk factors, probably I will maybe give a trial, I'll treat. But if I have a young patient, let's say somebody who's 25, 30 years old with isolated TSH increase, probably I will wait. And what Dr. Amit rightly said, even if you look at the guidelines, uh, for elderly people, TSH below 10, you don't intervene at all because the benefits are very, very doubtful. So I think probably either end of the spectrum, I'll wait. Middle spectrum, I will maybe treat.
Any other question?
So I had a question for you. So this Baxdrostat, we can use it now in primary aldosteronism patients because now we are detecting primary aldosteronism. We are looking for it in many patients with resistant hypertension. So this becomes a particular drug. Like for example, we are using aldosterone in those patients. So now.
I'm not sure if there are any trials for Baxdrostat for, you're saying Cons syndrome, right? Yeah. So Cons syndrome, I'm not sure if there are any trials. There's a company any information about use of Baxdrostat in primary hyperaldosteronism?
I can, I'm doing a trial on Vicadrostat, so I can extrapolate that to this, that it doesn't help in autonomous hyperaldosteronism. So if you have a non-locatable or non-located, non-tumorous hyperaldosteronism, that is the place where you can think of these kind of molecules. But where you have autonomous secretion, it's not going to work, because it is mainly on the secondary hyperaldosteronism that it primarily acts. So, of course, both these drugs are not available in the Indian market, but whatever brochure that I know of, it has mechanisms through two pathways. One is, I think the Baxdrostat is helping in not reducing the cortisol. So that is one fear that we have when we are using molecules like Vicadrostat, or that the cortisol can go down. But here this molecule seems to be very selective to inhibition of aldosterone alone, not the cortisol axis.
We had a wonderful listening to Dr. Anish today and Dr. Amit regarding the obesity assessment. So I just want to know whether do we have any biomarkers for obesity, so-called leptin levels or these adipokines. Do they have really any role while assessing their levels in blood, or in future they can be used for assessment of obesity?
Ma'am, they are there, but mostly in research settings. They are done in certain trials in PGI or AIMS. They are doing trials with that, and they are looking for the benefits. Certain are positive markers, some are negative markers. But I am not expert in that. I'll say, Dr. Anish.
I mean, in clinical practice, we don't do any of those tests. Clinical practice, all those markers, leptins and all are mainly for research. Probably we give it, I mean, most of the time when we see patients with obesity in large scale, we'll do the basic tests. I think now probably we should start thinking more in terms of moving beyond BMI, looking at anthropometry. You know, there is definitely a role for things like bioimpedance and DEXA going forward, because the information you get from those tests is much more than what you can get from just simple BMI or something. So probably a role for those things, and I'm sure in coming years we are going to have more amount of usage of these entities. But leptin, adipocyte, I mean, I don't think so we're going to do it. I mean, at least we don't do it as of now.
Yeah, if you have to talk theoretically, you have different markers in obesity. You have metabolic markers, you have inflammatory markers, you have hormonal markers, you have clinometric markers, and you have the historical, the what history taking that we have. So, if you see our Lancet article, which we have worked on in terms of outcomes, it gives all these markers. And if you have to ask me in clinical practice, do you really do it? We don't do it, but what you can interpolate or extrapolate through the markers that you commonly do. You do the inflammatory markers. So you, especially the metabolic syndrome in the lean, the so-called metabolically obese but lean BMI patients. There, the presence of inflammatory markers is one of the guidance where you can actually go very aggressive on treating these patients. So it may not really be guiding you to treatment of obesity, but the presence of metabolic syndrome can be guided upon.
Can I come on this from the cardiac perspective? You must have seen that all these pathology diagnostic labs do HSCRP, and it is a marker, and it becomes a big headache when the patient comes all the time with a high HSCRP value, and they come to cardiologist clinic saying that my cardiac risk is very high now. What shall I do? As you all know, that these were the research tools as we were studying, and they become available for the public. And there's no direct correlation between what is HSC, at least in clinical practice, there's no relation between how much is the HSCRP and how aggressive statins I'm going to go ahead with. See that whatever the calculators we use for ASCVD risk calculators. So we have QRISK-3 calculator, we have American College ASCVD risk calculator. So we use these calculators to decide whether to send a patient on a statin or not on a statin. And there are criterias. Let's say somebody's risk is more than 7.5% risk of 10 years CVD risk, then only patient will be started. So it doesn't consider how much is the HSCRP. So giving a wrong tool in population hands becomes a problem. So all these markers, even if they become available later on, should not be available for general public use. And we should, as a, I don't, nobody asks us in this country now, but because it's all commercial. That's what I mean. That company will decide that they want to do these markers, and they are done. They don't take input from a specialist saying that can we do this and can this be made. Actually, it should be like that. So you should not give a wrong tool in the hands of wrong people. And so having a marker will be good only for research purposes. Simple marker like what we learned anthropometric, like that's what the semaglutide and Munjaro are doing as well. So the weight loss is not much, but the inches loss is more. So we are using the waist measurement, or how much is your pant size dropped by. That is the best marker I think we can give to the population.
I think one point here is what Dr. Rahul rightly said is that all these labs which have these blanket 100 tests where half of those tests are of no use and the patient comes and eats your head. So I tell them very clearly that this falls out of my realm of specialty. Please go and meet the relevant people, because they will come and ask about chromium and all those metals, and it's so difficult. So I strongly believe that we should not be ordering these blanket tests for everybody and then trying to pick some test and then running on that in that direction. That's something which causes a lot of problems.
One point, basically in certain cases of monogenic obesities, where there is suspect of leptin gene mutation or anything, there these markers may help in addition to genetic tests.
Besides that also wastes the national money. So you can imagine the amount of money we are spending on doing a blanket testing, and this money goes to the companies which are selling the product or making those reagents.
Last question before the tea break. Yeah.
So another marker that always appears in every report is uric acid. Ma'am also said uric acid is now part of, but we cannot treat every uric acid. We know it's a marker. So ma'am, or anyone of you, how do you manage, how do you counsel, and when do you treat? Except for the cases of extreme, like gout or nephrolith. I mean, that also we're not very sure whether there is nephrolithiasis due to the uric acid or not. We can only be sure of gout. Where would you treat and which level, and how would you counsel the patients?
I mean, I think I'm not very clear about such clear-cut cutoffs above which we need to intervene or we don't need to intervene. But as you said rightly, if somebody has gouty arthritis, definitely they treat. And another thing which I have observed is that I really do not know how accurate is that a lot of orthopedicians, a lot of rheumatologists, I mean, ma'am will tell us that they treat uric acid even for patients with polyarthritis also. But I somehow don't know the linkage between uric acid and polyarthritis. There is definitely linkage with a particular joint.
Actually, the patient knows that all the pains are due to uric acid.
Yeah.
Oh, मुझे यहाँ भी दर्द है, यहाँ भी दर्द है, uric acid. So it is
So
like,
I think maybe ma'am will answer better.
Something.
I was part of the guidelines that wrote the Indian hyperuricemic guidelines. So I was part of the author of that guidelines. So this was a multi-society guidelines that we had published, I think, about a year back or the year before that. And what we recommended in the guidelines for Indian population was that if you have asymptomatic hyperuricemia, then you should not treat below 9. And if you have a symptomatic hyperuricemia, and this could be symptomatic in terms of either joint pains or cutaneous involvement or renal involvement, then below 7 you should not treat, but 7 and above you should treat. So that's really the guideline recommendation that we had put in for the Indian population, which was kind of the societies involved were the Indian Nephrology Society, the RSSGI, the API, and all of us had sat down, including the Cardiological Society. So that's the recommendation that we had really put up.
So if I may ask, what were the symptoms taken into consideration? Because the symptoms are quite vague.
So symptoms basically are, what you see, let's say patients have got gouty arthritis, gouty tophi, patients have got, presence of nephrolithiasis, or, so calcification. So, all these things were really considered in terms of symptom. Even arthralgia was considered.
Yeah, I agree with him that the gout guidelines, what they give, they do not advise to treat asymptomatic hyperuricemia, the levels below 9. And they say they don't find any evidence that treating this asymptomatic hyperuricemia really has any clinical outcomes. That's why the suggestion is not to treat the hyperuricemia per se with that but rather than treat the lifestyle modifications and focus on that. But the clinical guidelines are in the setting of gout, if you get those hyperuricemias above 7, you must treat them with one or more than one acute gouty arthritis, or in cases of chronic kidney disease with the metabolic syndrome, yes, then definitely you need to treat those hyperuricemias.
Polyarthritis and hyperuricemia.
Not really, unless it is. We do get polyarthralgias and hyperuricemia, especially in conditions which are non-gouty. In fact, the patients on AKT sometimes do develop this hyperuricemia and polyarthralgia, but that is secondary hyperuricemia. So we need to know the cause for hyperuricemia and accordingly treat it.
Just one more point. Uric acid is also very dynamic. So it's not like it's a fixed number. So if you correct the lifestyle, if you correct the diet, if you increase their exercise, then obviously uric acid will also come down like your HbA1c. So as a cardiologist, I also see a lot of raised uric acid amongst patients. So, but what I don't treat all of them unless they develop gout, which could be also because of drug interactions or drugs causing high uric acid, like diuretics, which we use a lot. So from our perspective, I always tell the patients to improve their metabolic syndrome by lifestyle measures and don't treat every uric acid unless you have to.
Thank you all for that excellent discussion, and thank you audience for that intelligent questions.
I would request all to be on stage. Now we are going to do a felicitation ceremony by Dr. Vaishali Deshmukh.
So welcome back to this case-based approach to obesity. And I would like to welcome Dr. Sanjay Agarwal for the first talk. He is a renowned physician from Pune dedicated to treatment of diabetic patients, rich experience of over 28 years and has patients from far and wide. Head of Department of Internal Medicine at Ruby Hall Clinic, Pune, and also senior consultant in diabetes at Jahangir Hospital and Apollo Group of Hospitals, Pune. We welcome you, sir.
Thank you very much, Vaishali, for inviting me to speak here today. And I'd like to thank you as well as Dr. Mukund for allowing me to speak out of turn. But I think it's a pleasure to be here amongst this august crowd. My talk is going to revolve around obesity and cardiovascular risk, because given the advent of so much of information about obesity that's coming today, but given the amount of information that's really coming in about obesity, but more important is today we are talking about risk reduction and how obesity can be managed because we have the tools for reduction of weight. And does it really translate into long-term reductions in the cardiovascular risk is something that we really like to look at very clearly. So this is going to be the outline of my talk. I'm going to start with the context, follow it up with the star kid on the block, and then of course the fallback, and finally of course what did we understand from this lecture that I would like to sum it up with. So let's set the context of my talk to say that what is the link between diabetes, obesity, and cardiovascular disease? And if you look at these figures over here, you have 86% of people with diabetes who live with overweight and obesity. 31% of people living with obesity have diabetes. 32% of people with diabetes have cardiovascular disease. More than 2/3 of deaths related to high BMI are due to cardiovascular causes. Approximately 50% of deaths related to type 2 diabetes are due to cardiovascular causes. 29% of people with coronary artery disease have diabetes. And more than 80% of people with coronary heart disease live with overweight or obesity. So clearly these numbers may sound very confusing, but all it just sort of sums up is that all these three conditions really interlink with each other and sort of magnify the risk for cardiovascular disease when they occur together and or even in singleton. Now there are multiple mechanisms that link obesity with cardiovascular disease. And we know that adipose tissue is an inflammatory organ which is responsible for secreting a lot of inflammatory cytokines, which sets in a process of inflammation. When you have a lot of adipokines and production of pro-inflammatory cytokines, it reduces the cardiometabolic fitness and creates a chronic low-grade systemic pro-inflammation. On the other hand, we also know that obesity is one of the cardiovascular risk marker, and it leads to dyslipidemia, hyperglycemia, hypertension, and obstructive sleep apnea. Obstructive sleep apnea, I'm sure Mukund is going to talk a lot about it. But what we really end up, because of all these high cardiovascular risk, is an increased atherosclerotic plaque load and increased arterial hypertension. So today you've got this perfect substrate where on one hand you've got an inflammatory state, the other hand you've got an aggressive atherosclerosis, and of course, independent of this, obesity itself is a strong predictor of cardiovascular disease. How does this really lead to heart disease again? Because when you have a lot of adiposity, it increases the cardiac workload, it causes a LV hypertrophy and fibrosis. And this adiposity leads to insulin resistance, hyperglycemia, dyslipidemia, hypertension, systemic inflammation, hypercoagulability. And this has a tendency for atrial fibrillation or heart failure, because today heart failure with preserved ejection fraction, one of the reasons that we find is a lot of cardiac steatosis, which leads to increased fibrosis formation. It's very akin to what we see in the liver, where you've got liver steatosis leading to fibrosis. And similar mechanism, you've got the epicardial fat and you've got the intramyocardial cardiac steatosis, which leads to a lot of fibrosis and stiffening of the LV wall, which is responsible for the heart failure due to preserved ejection fraction. The last bit is, of course, the ectopic fat, because we all are born with a finite adipose tissue storage. Now, when you have a spillover effect, when you've got a lot of accumulation of adipose tissue and you have the fat stores that are saturated, then these adipose tissue gets actually migrated to ectopic sites, maybe the liver, the muscle, the heart, the islets, and other sort of ectopic such perivascular species. And these are probably responsible for type 2 diabetes, heart disease, and mast cell. If you look at the data, and this comes from the CVD Lifetime Risk Pooling Project, where they looked at the association of mortality and morbidity with obesity. And here you're looking at different classes of obesity based on the BMI, and you have the structure over here where you have BMI more than equal to 40 all the way down to less than 18.5. You see a very strong correlation between the men and the women, because as the BMI goes up, the risk for cardiovascular morbidity and mortality tends to go up. We are familiar with the stages of cardiac, kidney, and metabolic syndrome. Today, why do we really talk about this? Because we see the strong interrelationship. And these are sort of phenotypes that present as translational into a disease process, an organ disease process. So why do we really put them into the staging process? Is because early intervention can reduce the progression. So if you look at stage 0, where you have no risk factors, and you're talking about primordial prevention of cardiovascular health, and this just translates into good practices, just good lifestyle practices, where you exercise, eat healthy, and look after your markers pretty aggressively. And if you have a family history, then obviously you start the screening process of the cardiovascular risk factors early. Stage 1 is, of course, excessive or dysfunctional adipose tissue, where people with overweight, obesity, abdominal obesity, and impaired glucose tolerance, this is a direct correlation between the visceral fat and occurrences of these diseases. And I think we had a question in the earlier session where they said that what are the best ways that we can assess obesity? And one of the strongest marker that we really look at is the waist to height ratio. And if you have a waist to height ratio of more than 0.5, and if you have a BMI of more than 23, then this is the highest sort of strongest correlation for cardiovascular risk that we look at. So this is simple to do in your clinics. look at the height, weight, BMI, calculate the BMI, look at the waist to height ratio. And in Indians, more than 0.5 is a very strong correlation to cardiovascular risk. Now, obviously, if you miss this stage and you're not really aggressive looking at adiposity, and the patient moves on to a typical metabolic syndrome where patients have got hypertension, hypertriglyceridemia, all the features of metabolic syndrome, moderate to a high risk chronic kidney disease in type 2. Here, of course, you're looking at all the aggression that we would like to see in terms of getting these to goal as per the guidelines. So you need to get them stringently to the recommended goals. Now, if these patients are left alone, they progress to subclinical heart failure, subclinical ASCVD. Any patient with obesity who comes to you with out of proportion shortness of breath, never ever forget that these patients could be having a subclinical heart failure, and your threshold to look at NT-proBNP should be pretty low to diagnose whether these patients are getting a heart failure with preserved ejection fraction. In a similar tone, the relationship of ASCVD, because patients with all these high adiposities and perivascular fat inflammation, they lead to an endothelial dysfunction and aggressive atherosclerosis. And most of these plaques are high lipid-rich plaques with less of fibrous cap, which ulcerates very easily, and you have occurrences of heart disease at lower levels of exertion or whatever you may talk about. Lastly, of course, patients do end up in stage 4, which is a full-blown end-organ involvement with strokes, coronary heart disease, heart failure, peripheral arterial disease, or AFibs that patients can come to us with. So our intention should not be to allow a patient to move to stage 2, 3, or 4, but we should try and restrict and identify patients in stage 0, stage 1. There's a terminology that it's a paradox really, where you say that healthy obesity. And what do you really mean by healthy obesity? Where patients have obesity and a normal metabolic profile. And these are the patients who we call as metabolically healthy obesity. But are they really risk-free? That's the key content that really we would like to look at. So most of these patients with metabolic healthy obesity are younger, they exercise more, and they have a high education level with low deprivation index. But in the UK Biobank study, most of these patients who were at baseline metabolic healthy obesity remained obese, but they became metabolically unhealthy after about 3 to 5 years. And they all acquired a higher risk for ASCVD. So if you look at the flow diagram on the right side, it's very self-explanatory, where if you have adipose tissue accumulation, so people have a high capacity for storage of adipose tissue, right? And they're safe. So as long as the fat stores are not saturated, they have a normal adipose tissue function, and they're at a low risk for cardiometabolic diseases. But the moment they start saturating, these patients who start getting weight gain and they start spilling over from the adipose tissue, then they behave exactly like patients who are obese with metabolically unhealthy, right? So they develop adipocyte hypertrophy, ectopic fat deposition. This leads to hypoxia, stresses, inflammation, adipose tissue dysfunction, and then release of atherogenic pro-inflammatory diabetogenic adipose cytokines and metabolites. Now, these patients who are low risk then convert into high metabolic risk. So it's basically, as long as the fat stores are not saturated, they tend to have a low cardiometabolic risk. But moment they spill over, they transform into from low to high cardiometabolic risk. Now, here's some of the obesity phenotypes and their association with cardiometabolic disease. So you've got patients who are metabolically unhealthy with normal weight. You've got metabolic healthy obesity. You've got metabolically unhealthy obesity. And then, of course, the sarcopenic obesity. And if you look at across all these 4 subtypes that we are looking at, and you look at metabolic syndrome, atherosclerosis, heart failure, AFibs, and cardiovascular events and mortality, all of them, by different markers, when you assess them, they tend to have a high cardiovascular risk. So all of these subtypes, when you look at whether they're metabolically healthy or unhealthy or normal weight, with metabolically unhealthy phenotypes, or for that matter, sarcopenic obesity. And you can see on the cartoon on the right side, where you look at all these people, despite the phenotypes, continue to have a high cardiovascular risk. This is another UK Biobank study, and this is a very interesting study where they looked at diabetes, obesity, and cardiovascular disease phenotypes. And this was something similar to the earlier slide. And they looked at two populations of people. They had patients with diabetes and no diabetes, right? And then they looked at what is the cardiometabolic risk that they carry with them. So people who are normal and non-diabetic are the index. All right. When you have overweight and non-diabetic, they don't really have a significantly elevated risk. When they're obese and non-diabetic, the risk tends to go up. But look at what happens the moment you add diabetes to obesity. You have patients who have normal but diabetes, the risk for cardiovascular disease almost goes up by 56%. When they're overweight and diabetic, the risk goes up by 71%. The hazard ratio you can see. And when you have obesity and you have diabetes, the risk goes up by almost 96%, right? And when you look at their, different intermedial thickness, it's directly proportional to the level of obesity and whether the patient has got diabetes or no diabetes. And that's the upper bar diagrams that you can see, including the fact that you look at the pulse arterial wave thickness, stiffness index, and you find that that also correlates very well. So what you're looking at is basically a lot of endothelial dysfunction, aggressive atherosclerosis, arterial stiffening that tends to happen in these patients, and then that leads to a high cardiovascular risk in patients. How much weight loss is really required for improving the cardiometabolic health, right? And you've got a host of other sort of conditions that are related to obesity, but for your cardiovascular outcomes reduction, you really need to look at 10 to 15% of weight reduction, which is today achievable given the pharmacotherapies that are there. So if you go back in history, we had either lifestyle intervention, which gave you about 3 to 5% of, improvement in the weight. And then you had the other extreme, where you had 30% and above, which was an indication for bariatric surgery. You had nothing in between which would help patients with obesity. Then, of course, came exenatide, liraglutide, which gave you about 6 to 8%, maximum 10%. But you continue to have that gap between 10 to 30%, which we really didn't have much solution to. But today, with all the dual agonists and triple agonists, you're looking at pharmacotherapies that can get you almost about 23% to 24%. We have just started a trial with amycretin, and with amycretin, you're looking at 24% of weight loss, which is very, very significant. And probably with these sort of agents, your indications for surgery are getting more defined. And you're looking at who are the patients who are really going to require a surgical correction, which is going to have a metabolic benefit. Does lifestyle have benefit? And this is from the post hoc analysis from the look ahead data. And you look at responders versus non-responders. And if you have more than 10% of body weight loss in the first year, does it translate into cardiovascular benefit? And the primary outcomes, there was 21% lower occurrences in the look ahead data, which was cardiovascular death, non-fatal MI, non-fatal stroke, or admission to hospital for angina. The secondary outcomes were 24% lower, and this was as above, as well as need for coronary artery bypass surgery, carotid endarterectomy, PCIs, peripheral vascular disease, or total mortality. So lifestyle intervention does work. You don't do away with it. Whatever you do in terms of weight management, you do it on top of lifestyle management, so you get an added benefit in these patients. I want to now switch tracks. And as I said, today we have definite, pharmacotherapies that change the outlook of obesity and cardiovascular risk. And that's why I say the star kid on the block is because we talk about GLP-1 RAs now more, and you're bombarded with everybody who comes and talks to you about GLP-1 RAs. But are all patients blanket, indication to receive the GLP-1 RAs? So let me first go on the first part of my lecture, that is really GLP-1 RA beneficial. And when you look at the meta-analysis the overall meta-analysis, MACE reduction is by about 15%, cardiovascular death is 15% again, occurrence of myocardial infarction is 12%, stroke by 19%, hospitalization for heart failure by 12%, and occurrences for chronic kidney disease 22%. Now, this is something new because we never related obesity with kidney disease. And today we have got robust studies because there's a lot of fat accumulation in the sinusoids of the kidney. And when you lose substantial amount of weight, you remove the fat from the sinusoids, and that's what leads into better kidney function. And there's a strong data that correlates between obesity and kidney disease. These are the cardiovascular benefits from various CVOTs, the 3-point MACE, and we've had these landmark trials, the leader trial with, we had with liraglutide, sustain 6 with semaglutide, the harmony with albaglutide, rewind with dulaglutide, pioneer again with oral semaglutide, and amplitude with the efluminitide. So all these have looked at positive outcomes in terms of CVOTs. So clearly there is a benefit when you look at 3-point MACE across the board with all the GLP-1s, and you can see the hazard ratio reduction anyway from about 15 to 30%. Clearly that benefits are seen from various GLP-1 RAs. And this is just a summary of the same CVOTs that we look at from the different GLP-1 RAs in terms of MACE, cardiovascular death, hospitalization for heart failure, all-cause death, and non-fatal stroke. You find that the benefits are there with all these GLP-1 molecules. But I'm now going to have a little more sort of time that I'm going to talk about with semaglutide, because that's something that is generic in our country, affordable, and reachable and accessible for most of our population. And you have today a flood of molecules with semaglutide that you're faced with. Does this semaglutide really work? Remember that the indications for semaglutide with the Indian molecules are only for obesity and mortality, but the innovator molecule has got across the board indications to use in cardiovascular risk reduction too. So this was a select trial, was a 3B randomized double-blind parallel group placebo-controlled trial. They enrolled about 17,500 patients more than 45 years of age. BMI was more than 27 with no prior history of diabetes. And they're randomized between semaglutide subcutaneous 2.4 versus placebo. And they looked at, these were patients who had prior MI, prior stroke, or peripheral arterial disease. And this was event-driven. So the primary endpoint was, of course, time for randomization to first occurrence of a composite endpoint, which could be CV death, non-fatal MI, or non-fatal stroke. Here's the results that you could see over here, that primary cardiovascular composite endpoints, there was 20% reduction. Death from cardiovascular causes, 15% reduction. Heart failure composite endpoints was 18% reduction. And death from any cause was 19% reduction. So clearly, semaglutide worked in all these patients. What about when you look at adiposity measures and MACE in the same select trial that we're looking at, and you're looking at subgroup analysis based on BMI, based on body weight group in terms of kilograms, waist circumference, and then waist to height ratio that I really talked to you about. When you look at all these subgroups across the board for all the adiposity measures, you find that reduction helps the cardiovascular risk reduction. So select trial clearly came out that when you look at the subgroups of BMI, the higher the BMI, of course, the higher risk, but you just bring down the BMI, bring down the waist circumference, bring down the weight, and you reduce the waist to height ratio. It has benefits in terms of cardiovascular risk reduction with semaglutide. Again, when you look at heart failure, whether it's preserved or reduced ejection fraction, and this is again when you looked at both the preserved and reduced ejection fraction, the risk reduction with the heart failure across both the subgroups was lower in the semaglutide group as compared to the placebo. I just want to look at other GLP-1 molecules, tirzepatide, and the SURMOUNT-1 trial. You have a good weight loss that tends to happen with tirzepatide. And here you're looking at about 2,500 population, BMI between more than 30 or more than 27 with one comorbidity, excluding type 2 diabetes, and who had an unsuccessful attempt at losing weight despite dietary effort. Now look at the weight loss in patients with obesity and who received tirzepatide. The waist circumference was looked at. There was significant reduction. Diastolic blood pressure, systolic blood pressure, there was a significant reduction. LDL cholesterol, triglycerides, and A1C, there was significant reduction with 15 milligram of tirzepatide daily. So clearly, all the cardiovascular risk markers benefited significantly in the tirzepatide group as compared to the comparator. This is, of course, a meta-analysis that we looked at 8 studies with tirzepatide, and you look at acute coronary syndrome, you had a 26% reduction, heart failure 35%, stroke reduction 29% reduction, MACE events 28% reduction, and all-cause mortality was almost like 51% reduction, and composite outcomes of all-cause mortality plus CV outcomes was 35% reduction. So all these favored a weight reduction, but it was not just the weight reduction that really mattered. It was also the tirzepatide by different mechanisms that really improved the goals. If you achieve a BM of less than 25, does it give you an additional benefit? And this was seen in the post hoc analysis in the SURMOUNT 1, 3 and the CN trials. And if you look at all these subgroups, you find whether you look at overweight, EGFR, NAFLD, you're looking at obesity and all these different conditions, even in pre-diabetes, you find that going lower, even BMI of less than 25, had additional benefits when they're followed up over a period of time. The same thing again with orforglipron. We're going to do this, we're going to have this molecule shortly in this year, and you have similar results that are seen with orforglipron. Now, why did I really bring up orforglipron over here? We had 2 important trials that were discussed this year in the ADA. And one was the SURMOUNT Maintain trial, and the other one was Attain Maintain trials. The question always comes is that when you have achieved the maximum weight loss with the maximum tolerated dose, when is the optimum period? So the question always comes that how long do you need to continue the GLP-1 molecules? And are you going to have preservation of the cardiovascular risk reduction? So both the trials showed, they looked at semaglutide and tirzepatide, and in the Attain Maintain trial, they looked at both the tirzepatide and as well as the semaglutide. When they were shifted to oral GLP-1 orforglipron, you found that there was a very marginal weight regain of about 5%, but they tended to have a preservation of reduction of the cardiovascular risk. In the SURMOUNT, they moved tirzepatide 15 milligram to 5 milligram as a maintenance dose, and they found that a lower dose of maintenance continues to give you the benefits with a very marginal weight regain. So it's when we look at patients who are on GLP-1 analog and you're looking at what do you want to do with these patients in long term in terms of maintenance, it's a good idea when they've got a sort of a maximum weight loss that you've achieved, you can shift them to oral GLP-1s and maintain them on oral GLP-1s. This was the FLOW trial. This is, of course, on the background of kidney disease the patients had, and this was the EGFR sub-analysis, and you found similar improvement in this meta-analysis in the different, cardiovascular endpoints. I just want to now come up to the last bit is where bariatric surgery, does it help? Yes, when you have people with morbid obesity, where you have limitation in terms of improvement with GLP-1. So patients who've got 40 and 50 BMIs, it's very unrealistic that you can get with only a GLP-1 or kind of a weight reduction that you're looking at. And often we ask these patients to go through bariatric surgery and then follow them up with perhaps a GLP-1 analog. And you have both the laparoscopic banding and Roux-en-Y, and you find that in both these sort of subsets of population, when there were mortality looked at in 4.5 years, there was 1.3% reduction in surgical patients and 2.3 in the non-surgical reduction. So mortality was higher in the non-surgical patients. SGLT2 inhibitors, again, are complementary, and these are some of the reduction that you see in the endpoints with SGLT2 inhibitors. For want of time, I have not really included the trials related to SGLT2, but today we find that there are complementary mechanisms of action between GLP-1 and SGLT2 inhibitors. We are looking at today that who are the subsets of people who will really benefit from GLP-1 and SGLT2 inhibitors? And can we look at their inflammatory phenotypes to decide that who are going to be benefited with GLP-1 versus SGLT2? So here's a host of inflammatory markers that you really look at. So you look at, of course, systemic inflammation with hsCRP, IL-6 and TNF-alpha, or endothelial dysfunction with flow-mediated dilatation or adhesion molecules or albuminuria, epicardial coronary inflammation or adiposity. You have definite sort of markers that we have looked at to say that are these going to be benefited with GLP-1s or SGLT2 inhibitors? And which brings me to the next slide, which was published this year, that based on the assessment methods and the clinical significance, you could clearly identify the subsets of population who are going to benefit with GLP-1s versus GL or SGLT2, or with complementary actions of both GLP-1 and SGLT2 inhibitors. So I'm just going to talk the false side, okay? And we said that suppose you just take GLP-1 analogs and you quit the GLP-1 analogs, you've had a substantial reduction and benefits in cardiovascular outcomes. And these patients, what do they happen when they stop the drug? So clearly weight regain remains an important problem and patients get their weight back. And these were like almost 9,000 odd titles screened, 37 studies were included, treatment duration of about 39 weeks and follow-up of 32 weeks. The average weight regain was 0.4 kilograms periodically. That was studied. So people put that weight back up again. The question is that if they put the weight back again, what happens to the cardiovascular risk? Everything comes back. So you are benefited with GLP-1 analogs so long as you're continuing to take them. The moment you quit, you look at the graphs, all of them go back up, whether it's A1C, fasting glucose, systolic blood pressures, total cholesterol, diastolic blood pressures, or triglycerides. All of them go back to the baseline levels. So the message here is that if you're giving it for cardiovascular risk reduction and you're not looking at mechanical benefits of GLP-1, then these have to be continued on a longer duration of time on top of lifestyle management, because the benefits last as long as you continue to take them. So I just want to end up with a summary to say that what did we really understand from this lecture? We know that obesity is a primary driver of CKM syndrome. South Asians carry a disproportionate risk at lower BMI levels. So if you look at all the studies, we have low BMI, but we have a high adiposity, which puts us at the similar risk as somebody who's got a high BMI and a high sort of, high cardiovascular risk. Weight loss of more than equal to 10% shifts hard CV outcomes. And you treat obesity as you treat hypertension and dyslipidemia, which means that it is not a short-term goal treatment that you're really looking at. You don't stop an antihypertensive. You don't stop anti-diabetic medications. You don't stop an anti-lipid medications, right? You still need to continue taking obesity-reducing medications to have a sustainable benefit. There's now, of course, the European Society of Cardiology recommendations, where we say that glucose-lowering medications' effect on weight loss should be considered in all patients with overweight and obesity to reduce weight, but as well as to improve the cardiovascular disease risk profile. So the pharmacological weight reduction, you have good agents that have come in. GLP-1s, of course, are the most significant, which enable significant and sustainable weight loss, but they are transforming clinical care and they're reducing risk of future diseases. They're not just obesity treatments, and they benefit the biology of multiple diseases of aging, not just cardiovascular disease. The main issues to be resolved regarding the best use of these novel therapies, including now, which we really don't have an answer, is how long and how much, right? That is something we are still at loss to understand there. And pharmacological weight-reducing agents have the potential to revolutionize healthcare by treating the causes of cardiometabolic disease with benefits, not just for individuals, but also for the economy and for the society. So I'd like to thank Vaishali once again, as well as Mukund, for giving me this opportunity to come here out of turn and to give this lecture. And I'd like to invite all of you to the IDEC meeting, which is going to be this year. But I have last two slides I forgot to speak about. In 30 seconds, I'll cover that. We're looking at multiple clusters which are looking at for risk stratification. Which is the best cluster for predictive analysis? So you're looking at predictive algorithms, and you're looking at is metabolic health, is diabetes clusters, is genetic based clusters, or are we looking at type 2 with the high risk or tree methods, which have the best predictive value in terms of risk prediction? And you can choose your clusters and decide that which suits your patient population the best, and you can adopt these clusters. The bottom line is, of course, on top of every care, statins, ACRBs, SGLT2, GLP-1s today have become the mainstay of treatment for all our patients with obesity and cardiovascular risk. So thank you, and my invitation to all of you to attend the IDEC meeting this month from 21st to 23rd August. Thanks you once again.
Thank you, sir, for this enlightening talk. And I'd like to invite the audience for any questions. So maybe I'll ask you a question then.
Yeah, please.
Okay. So one of the difficulties in counseling patients when we want to put them on a GLP-1 is that how long will the medication go on, or how long should they be on these injections? So how do you counsel, and what is the best way?
That's a good question that we really, and I'm sure that as much as you, we are faced with the same question, that how long do I need to continue? Now, if you look at all the trials and data, and as I said during the course of my trial, this has to be permanent medication, just as you give an antihypertensive or an anti-lipid medications, because the benefits are only as long as you continue the medications. So my answer to the question when the patients ask me this is that you don't stop them. You have to continue the lifestyle interventions. That's obviously mandatory. But we need to see that cost becomes an important consideration, and people are quite intimidated with the fact that they need to take a lifetime medications. But then you weigh the risk and benefits across the board, and we tell them that, okay, today you have oral options available, number one. Number two, that do you need to take weekly GLP-1 analogs after as a maintenance, right? So very often, a lot of us who practice obesity and practice the obesity medicine, we do tell them that, okay, you can sort of stay on lifestyle. Intermittently, you could keep continuing to take the GLP-1s, and there's data to show that also, that when they find that the graphs are going up, you introduce and you can take them on intermittent GLP-1s, and the benefits continue to exist. You can shift them to oral medication, which is more acceptable to them to understand, right? So that's your best way to counsel them, to say that if you're looking at secondary prevention, it's far more easy because he's had a problem and he's very scared about it. The problem occurs when you're looking at primary prevention. And in those patients with primary prevention, it's always a challenge to keep them on the medications. And you have to just use your wit and your knowledge to see how you can convince them.
So by intermittent therapy, what did you mean by expanding
So we keep
the
them
gap?
on a low dose maintenance therapy. So you may keep them on 2.5 to 5 milligram of tirzepatide. So people have used this and they have shown this in trials, that you give them, let's say, every alternate week, and that could reduce the frequency. Right. And they have looked at, does the burden and the risk profile stay low, and that continues. So just as we're looking at maintenance dose, we're looking at, let's say, 15 milligram coming down to 5 milligram, which was a Surmount Maintain trial, which looked at the same issue. Or you look at converting injectable to oral, which was the Attain Maintain trial, and you found that the benefits continue to be there. The trials that are now being done is, do you need to give them on regular basis, or can you give them intermittently? But of course, aggressive lifestyle continues to be on board, and you need to see that the goals are met. Whether you look at lipid goals, you're looking at blood pressure goals, you're looking at A1C goals, you're looking at waist circumference, you're looking at the waist height ratio. Are you meeting these goals, which will give you the benefit?
Thank you so much, sir.